and I'll hand over the session to you.
Yes.
Okay.
Protocol.
Okay.
Right, ma'am. So with your permission, thank you everyone. Good morning and for joining this webinar. I am Dr. Amit Borse, a Senior Product Manager with IVA, division of MCure Pharmaceuticals Limited. We at MCure are on a mission to nurture and support 28 days. Programming 28 is a scientific theme for the year, and hence our webinars are called Programming 28 Webinars. We are thankful to all the Solapur Obs and Gynec Society for giving us an opportunity to host this event. I am also happy to announce that this is our 97th webinar in last 3 months, and this will soon be shared with the fraternity on IVA IVF Virtual Academy platform. To start with the session, may I now introduce Dr. Kiran Sarda ma'am. Dr. Kiran Sarda ma'am is a director of Sarda Hospital, Solapur. She's practicing Obs and Gynecology since 1994. She's the president of Solapur Obs and Gynec Society, served as IMS secretary. She was also AMOX conference treasurer. She's the Hospital Owners Association secretary, director of Hegrewar Blood Bank, vice president of Inner Wheel Club Solapur, BOD of Solapur Rotary Club. We also have with us Dr. Madhura Virkar ma'am. She is the secretary for Solapur Obs and Gynec Society, and she's practicing at Virkar Hospital. May I now hand over session to Dr. Kiran Sarda ma'am for taking it ahead.
Thank you, Dr. Amit, for kind introduction. Madhura, let us start the session now. Hello, Madhura.
Not audible.
Madhura ma'am, should we go ahead with introductions first?
Hello.
Yes, now you are audible.
I think there is some problem with my speaker. Okay. So we will start with our first session. The speaker will be Dr. Milind Patil sir, and the chairpersons for session are Dr. Pandit Palaskar sir and Dr. Aboli Velankar madam. And now I hand over to Dr. Sarda madam for introduction of the chairpersons.
Hello.
Hello.
A warm good morning to one and all. I welcome all of you in this today's webinar on art. In this webinar, we are going to have 2 lectures from the speaker. First will be thin endometrium by Dr. Milind Patil, and second will be ovarian reserve by Dr. Raju Dabde. I welcome all the speakers. After that, we will have a discussion with experts in which Dr. Asha Bakshi, Dr. Milind Shah and Dr. Kalyan Barmade will be giving us their expert opinions. I welcome all of you, all the speakers, chairpersons in this webinar. For this first lecture, thin endometrium by Dr. Milind Patil. Chairpersons, I invite chairpersons Dr. Pandit Palaskar and Dr. Aboli Velankar. Dr. Pandit Palaskar is gynecological endoscopic surgeon and IVF specialist. He is director of Endo World Hospital, Aurangabad, which is a FOXY and IAG recognized center. He is at present president of Aurangabad OBGYN Society. He is joint secretary of IAGE, invited as faculty at national and international conferences, published many papers in journals. I welcome Dr. Pandit Palaskar. Dr. Aboli Velankar, she is director and consultant at Nirmala Hospital since last 28 years, giving practice of OBGYN in Solapur. At present, she is vice president of Solapur OBGYN Society. Very silent and soft-spoken person and one of the leading private practitioner in Solapur. Now hand over to Palaskar and Velankar.
Yeah, hi, good morning everybody. It has always been a great pleasure to be with Solapur OBGYN Society. We have wonderful friends from Solapur like Dr. Dabde, Dr. Milind Patil, Milind Shah, Dr. Kiran Sarda, and so many good wonderful friends we have from Solapur. Now we'll start the webinar. We have the first session as thin endometrium of all the factors in fertility, endometrium is the most important as it is an end organ. We cannot replace endometrium. We can replace the embryos. We can replace the oocyte. We can replace the sperm. But the endometrium is such a factor. We cannot replace it. We have to evaluate and treat it properly. Thin endometrium is the most difficult to diagnose and treat. We have expert speaker Dr. Milind Patil. I am sure he'll guide us how to evaluate and treat the thin endometrium. Dr. Milind Patil is a practicing endoscopic surgeon and ART specialist at Shobha Nursing Home, and he has a very thorough knowledge regarding the infertility and ART. And whenever I have any difficulty, I don't feel any hesitation to call him. Over to you, Dr. Milind Patil.
Milind, please unmute yourself. Dr. Milind. Yeah.
Thank you, Pandit. A very good morning to all, and sorry for a slight delay. Actually, the connection, it was not getting connected. First of all, let me thank everybody, the SOGS and Kishore Moe for organizing such a wonderful event. And I'll right away start with the talk. Actually, I spoke to Dr. Sada and I said, rather than putting on slides and going through the usual formalities, I thought I will be more interactive and try to tell whatever experience I've accumulated and what I feel about it. So like we all know, endometrium, it is derived from the mucosal lining of the fused Mullerian ducts, and it is essential for reproduction. And it may be one of the most complex tissues in the human body. It's always changing, responding to cyclical estrogens, progesterones, etc., and a complex interplay, and of course with the own autocrine and the paracrine factors. We all know, just to brush up, upper 2/3 is a functionalis, which contains the stratum compactum, which is the superficial layer. Then comes the stratum spongiosum, and you have the basalis layer, which is the most important, because from there the regenerative activity of the endometrium every month to month cyclically goes on. The upper 2/3 functionalis, basically it's regenerating, it gets shed off during the menstrual period, and it is responsible for the implantation of the blastocyst.
Dr. Patil, excuse me, are
Yes?
you sharing your screen?
No, I'm just speaking this way only.
Okay.
Huh? Okay. Then, of course, now coming to the endometrial receptivity proper, like first of all, the most important thing is you need to define what is thin endometrium. So thin endometrium, basically it is, most of the studies take the cutoff as 7 mm, but then some studies have quoted it as, but now we'll go practically, we'll take it as a 7 mm as a cutoff. So anything below 7 is called as thin endometrium, and above 7 and above will be a normal endometrium. So how do you measure this thin endometrium? You have to do a good transvaginal, you have to have a good transvaginal ultrasound machine, a good transvaginal probe. You put it in the sagittal section, and then you have to measure it at right angles to the thing. The sagittal, you have to be sure that the sagittal section, it covers the entirety, right from the cervix to the fundus. So the measurement is more important, because if you have any fallacies or if you measure it in the wrong way, the other things will also go wrong. And then what do you see in the endometrium? You see the thickness, then you see the morphological pattern, it's trialaminar, it's echogenic, secretory, etc. For the blood flow, the subendometrial, endometrial blood flow, and the volume. But the most important, I think, is the thickness and the morphology. And of course, maybe the blood flow, which I normally just switch on the color and just see it. Okay, then, of course, when we know that Einstein had always said, okay, if you can't explain it simply, sometimes we don't understand it well enough. So we are not able to explain it. So now why endometrium is important? It is most important because it's the embryo-maternal communication takes place through the endometrium, implantation, the pregnancy grows there. So the endometrium has to be important. Now, if we take an IVF, about 70% of the time, it's the embryological problem, or it is the embryo which is responsible for the implantation. About approximately 20%, it is the endometrium, and in 10%, there are some factors which are yet unknown, maybe some part embryological, some part endometrial, and then some other factors. Now, coming to the receptive endometrium, what does a receptive endometrium basically require? It requires estrogen priming, time-related progesterone, and of course, other molecules which are responsible for it. Now, we don't have any ideal way to measure an endometrial receptivity. So like you have to have a sensitive, specific marker. It should be accurate, non-invasive, cheap, acceptable to the patient, and easily available. So like I initially said, endometrial thickness is done by ultrasound. Then when the ideal thickness, if it is between 9 to 14, you have the most optimum pregnancy rates. And if it goes below 7 mm, you have a gradual trend of reducing pregnancy rates there. So about the thin endometrium, we have various studies here. Like we normally now there has been a study. Am I audible?
Yes, yes.
Okay. So in fresh IVF cycles, if we talk about, so there the cutoff, we have taken it as 8 mm. And in a frozen thaw cycle, because many times we down regulate, so we don't find the endometrium that thick as we find in a fresh cycle, or when we are using the patient own endogenous estrogen, like in ovulation induction or in IUI or in IVF cycles, where the endogenous endometrium estradiol is in play and it is stimulating or proliferating the endometrium. In frozen cycle, the woman is many times down regulated, and so she has to depend upon the external estrogens. So the cutoff for fresh cycles IVF is 8 mm, and for thaw cycles it is 7 mm. So how does, of course, then why this thin endometrium is important? So what is the incidence of thin endometrium? In ovarian stimulation cycle, it varies a lot. It goes between 38 to 66%. In IVF, it is about 1 to 2%. But of course, these are all based on retrospective and prospective studies. Ovarian stimulation cycles are more likely to proceed despite the thin endometrium. But IVF cycles, we always have the option of freezing the embryos and cancelling it and doing ET in a later cycle where we can have a better control on the endometrium. But in ovulation inductions in IUS, if we find a thin endometrium, we generally don't tend to cancel it and we just go ahead with the procedure. Either it's ovulation induction or it's IUI. So now how does this thin endometrium affect implantation? It causes basically poor growth of the glandular endometrium, decreased vascular endothelial growth factor expression, poor vascular development, and higher resistance in the radial arteries, which of course reduces the vascular endothelial growth factors, reduces blood flow, thin endometrium, and vascular resistance. So does it really matter? The likelihood of achieving an endometrial thickness more than 8 mm decreases with age. As the woman's age increases, especially when she goes beyond the age of 40, even if she doesn't have any history of endometritis or DNC or anything else, risk factors, but still because of the age, because of the senescence, her endometrial thickness goes on decreasing. But nevertheless, the viable pregnancy rates remain reasonably acceptable in patients, even with an endometrial thickness between 4 to 6 mm. Now, how thin is the thin endometrium? So, like I defined already, a fresh cycles, we can take the cutoff as 8, and in frozen embryo transfers, where we are preparing the endometrium by estrogen and progesterone given exogenously, it has to be taken as 7. Now, what are the causes of thin endometrium? We have clomiphene citrate related when we start in general practice, like we do ovulation induction IUS. So clomiphene we all know is an anti-estrogenic, so that may cause this an iatrogenic cause of thin endometrium. And you have postpartum endometritis, you have septic abortions, you have chemotherapy, radiotherapy, in utero, diet, cholesterol, hypothalamic hypogonadism, fibroids, anomalies, premature ovarian failure, where you have basically low endogenous estrogen, hyperandrogenemia, iatrogenic, and of course idiopathic. In idiopathic, what you mean is sometimes without any history, the patient is absolutely normal laparoscopically, hysteroscopically, but somehow even with high doses of estrogens, she is not able to develop the endometrium. So it is an inherent, we cannot say it's a problem, it's the inherent endometrial architecture which doesn't support the growth of the endometrium beyond a certain point. So first step is we have to find out the cause of thin endometrium. So how do we do this? Of course, we have some diagnostic modalities, like we have hysteroscopy, sonography, MRI, but I'll come to the point that we basically go for hysteroscopy because it is interventional also. So you can put in a scope, you can see many times a thin endometrium does validate a good hysteroscopic examination. So if you find some adhesions or you find fibrosis, you can always go for hysteroscopic adhesiolisis, and then you can post-operatively put in a Foley's, and you can go in for high-dose estrogens post-operative, and then you can hope the endometrium goes to some threshold where we can go in for her ART treatment. Of course, then sometimes endometritis can also be diagnosed on hysteroscopy, like you have a stromal edema or you have micropolycene, and of course, in the HPR, the gold standard will be a plasma cell, which we see. But then practically in hysteroscopy also, many times you are able to identify chronic endometritis, especially in a country like India where tuberculosis is very endemic. Then we have to treat the cause. Many times thin endometrium is an expression of something going on beneath. So many times, rather than the thin endometrium, it's the etiological factor which is responsible. I think so now, so what are the causes? Endometritis. Like I said, if you have a subclinical tuberculosis, if you have subclinical endometritis, you need to treat the infection because that is responsible for this infertility. It may be also be responsible for the recurrent pregnancy losses. Intrauterine adhesions, endometriosis, hydrosalpinx. Of course, hydrosalpinx leads to concurrent endometritis and also fluid accumulation of fluid in endometrium that has to be treated. So thin endometrium in fresh cycle, what we need to do? So like you are doing ovulation induction, you are doing IUI, or I'm talking in general for everything so that all the audience will benefit from it. So changing the protocol rarely helps, except maybe in ovulation induction or in IUI where you are using a CC, you can change to tamoxifen or you can use letrozole. So obviously tamoxifen has got more better effect on endometrium. Tamoxifen basically acts by two ways. First is centrally acting, it increases endogenous estrogen because of the follicle stimulation. And second, independent of this endogenous estrogen, tamoxifen has got a direct stimulatory effect on the endometrium. So I've seen many patients, even if a follicular development is not there, especially in HRT, and if you give tamoxifen, you have a good endometrium growing because it has got a direct effect on the endometrium independent of the endogenous estrogen. So you can use tamoxifen, which is a better choice, especially when you are preparing a patient for an FET. But in ovulation induction IUIs, you can go in for letrozole or the other choice. Of course, the drug of choice nowadays is letrozole for ovulation induction in many patients. And the second choice will be tamoxifen. You can add estradiol also in many patients. When you're seeing, when you're stimulated with CC, you find the endometrium is thin. You can add estradiol. We have lots of adjuvants. Or of course in ART, if you have done pickup and you find the endometrium is thin, you can go in for segmentation or freeze-all strategy. So changing of the stimulating protocols, especially in IVF or ART, there's insufficient evidence that changing the protocols, changing the stimulation protocol will help to increase the endometrium. So the evidence there is weak, the quality of evidence. But then there were some studies in fertile study in 2005 where addition of luteal phase estrogens in stimulated cycle after the pickup may improve the pregnancy rate. Of course, there are many studies which are also citing that addition of luteal phase estrogen doesn't help. Then, of course, 2 milligram, 4 milligram, or 6 milligram. This study showed that if you have a 6 milligram estradiol support in luteal phase, whenever there is a thin endometrium documented in that fresh cycle, it may improve the pregnancy rates. So, but the latest Canadian guidelines, which came in 2019, so they recommend the estrogen adding estrogen in the luteal phase will have no effect on the pregnancy rates. So now coming to the various adjuvants which are used in, of course, before going to the adjuvants, I would like to touch upon the endometrial preparation for FET in a very brief manner. We do it in a natural cycle, we do it in a hormone replacement cycle with or without down regulation, and we do a stimulated cycle. So, of course, there is no evidence that some work better than other, the protocols which we use in frozen embryo transfer. So, any good endometrial preparation in an FET is fine as long as the endometrium is beyond 7 millimeters. It is trialaminar. Of course, then there are various estradiol preparations which we use. Ethinyl estradiol, conjugated estrogen, estriol, estradiol, transdermal patch and gel. Normally, worldwide, majority of the centers use estradiol valerate because that is time tested, that has been used for various trials, and we have been using it since so many years and with good results, enough results. With ethinyl estradiol, you have increased triglyceride, you have increased PRS, which increase the hypertension, which have got some increase in the factor 7 also, which also has got more procoagulant factors. So conjugated estrogen, again, it is equine estrogen, so interbatch variability, allergic reactions, and of course it's a procoagulant as well. Patch in tropical country like India, sometimes because of sweating may not stick well to the skin, so then that, yeah, there you can go in for an estradiol transdermal gel. I normally prefer to use oral estrogens, and if we find that endometrium is not growing properly, we can always supplement it with a vaginal one. If you can use a vaginal proguanil always dissolves nicely in water, so you can use vaginal estrogens also. And if it doesn't work also, then you can even try a supplemental dose of a transdermal gel. The basic idea here is, if you are trying one route of estrogen, if it doesn't help, try to use different other routes also where it may help. So about the duration of estradiol therapy, what's the duration of estradiol? Estrogens can be given up to 4 to 6 weeks, and it doesn't decrease the endometrial receptivity. So you can very well continue, and instead of increasing the dose per day, you can always go in for a more prolonged therapy, so which will improve the endometrial lining without affecting the endometrial receptivity. So 4 to 6 weeks, up to 4 weeks, 5 weeks, we can always use without worrying about the decrease in the endometrial receptivity. Okay, about the adjuvants. Now there are so many adjuvants. We have sildenafils, oral, vaginal, we have aspirin, we have L-arginine, we have tocopherol vitamin E, we have pentoxifylline, we have GCSF, we have platelet-rich plasma, and the stem cells. More or less, we do use it, of course, because sometimes we have to practice anecdotal medicine when we know if nothing is working, and if it doesn't harm the patient, we can always try it. But then more or less the randomized trials, the recent one, and the Cochrane reviews have shown that more or less these are not much effective in increasing the endometrial thickness. So we use sildenafil, we use vaginally to circumvent the oral effects, we use aspirin, we use L-arginine, vitamin E, pentoxifylline. GCF is also been used, but all these have got no strong evidence. If at all there is any evidence, is a very weak evidence. Of course, the stem cells with the autologous bone marrow stem cells which has been used has proved promising, but it needs larger reviews, larger trials, and then it can be inculcated into a normal practice. So I'll just breeze through that, because we know that we are using it: pentoxifylline, tocopherol, GCSF, etc. PRP. I was using PRP nearly 4 years back. I did a lot of about 100 patients of PRP, but I didn't find any, this was my own data, and I didn't find any much improvement in the pregnancy rate. Even if there's a slight improvement in the endometrial. See, there are two different things. Increasing the endometrial thickness, whether this translates into increasing the implantation rate, decreasing the miscarriage rate, and the live birth rate, which is the final outcome of any infertility treatment. So it doesn't improve any of this. It doesn't improve the live birth rate. So still, a lot of research is needed and a lot of trials need to be done before we can definitely recommend about this all. Of course, HCG is there. Many doctors also use GnRH agonist in the luteal phase in the hope of increasing the FSHLS, stimulating the corpus luteum, and in short, effectively increasing the endometrial thickness. Scratching, of course, we know the latest trial, especially if it's the first IVF cycle, doesn't help, doesn't improve into this. So the latest guideline, 2019 Canadian Fertility and Androgen Society guidelines, they suggest against the use of aspirin, vaginal sildenafil, GCSF, I'm reiterating again, pentoxifylline, HCG, gonadotropin releasing agonist, platelet-rich plasma, or stem cell. So the quality of evidence in all this is weak. Of course, in non-IVF cycles, what we should do, if we are stimulated a patient with, like I already told, with clomiphene citrate, with gonadotropins, without gonadotropins for ovulation induction IUI, I think even if the patient has a thin endometrium, maybe 6 or 7, we should not cancel the cycle, because these patients also carry a reasonable prognosis of getting pregnancy. If you cancel an IUI, she is not going to get pregnant. The pregnancy rate will be 0. So instead of that, you will have some chance. Of course, it will not be as good as 8 or 10 or 12 endometrium, but definitely she will have a chance. So it's always worthwhile to continue the stimulation and continue the procedure. Of course, they have used concurrent estradiol, Valerate along with it. It does improve the endometrial thickness, but it doesn't translate into increasing the pregnancy rate and the live birth rate. Then the other alternatives will be, you can change the protocol, you continue this procedure, you finish this. If the patient doesn't get pregnant in the next cycle, maybe you can change to letrozole or tamoxifen. And of course, what do you counsel the patient about thin endometrium? Actually, like I told you, 7 mm will be the cutoff for FED cycles, fresh cycle will be 8 mm. You can always tell the patient there is a statistically decreasing trend. It is not like that, less than 6, there will be no pregnancy. That is absolutely wrong. Less than even 6 mm, there will be no pregnancy. We do get pregnancies, but of course, the statistical probability of getting pregnancies is low. So there is a statistically decreasing trend as the millimeters of endometrium goes. Like we have put a cutoff of 8 mm and 7 mm. 1 millimeter decrease in the thickness of the endometrium will reduce the statistical probability of pregnancy in that particular cycle. So what will be the take-home message? Thin endometrium is a frequent, challenging occurrence in assisted reproduction. Balancing the prognosis for the patients is important. If they proceed with the treatment with a thin endometrium, you can always consider the alternatives. In ovulation induction, you continue the process, you finish it, patient may get pregnant, doesn't get pregnant, maybe you can change the protocol in the next cycle. But of course, we have a luxury in IVF or in ART where we can always do a freeze-all if you find the endometrium is not good enough for the fresh transfer, and you can always get a better endometrium by modifying the protocols, by giving it for a prolonged period of estrogen and done for transfer. So currently there is a minimal evidence to support any specific protocols or adjuvants to significantly improve the pregnancy outcome, apart from when we treat the etiological causes of the thin endometrium, and where we can then hope maybe the endometrium will grow in terms of anatomy or function. Thank you so much.
Thank you, Dr. Milind Patil. Am I audible?
Yes.
Yes.
Yes. Thank you, Milind Patil, doctor, for your excellent lecture. And you have put a lot of light on this important topic of thin endometrium. There are many protocols for induction of ovulation, but the success rate of the IVF cycle depends on the quality of the endometrium. And it is very important for the general practitioners practicing infertility and also the IVF consultants. Some more introduction about Dr. Milind Patil. He is a very successful IVF consultant in Solapur. He is very passionate about his work and has always updated his knowledge in IVF, and due to which many patients in Solapur as well as nearby towns have the advantage of it. He has participated in many national and international conferences and has always strived to maintain the standards of IVF. Thank you so much, Dr. Milind Patil.
Thank you so much. Thank you.
Madam, can I have some few questions? Or will I have a question at the end?
Yes, you can have.
Yes, we can have.
Yeah, so it's always a great pleasure to listen you. I have a few doubts. Among various estrogen preparations, like estradiol valerate, hemihydrate, succinate, which is your estrogen preparation of choice?
Okay, that's a good question. Actually, like I told you, we are using estradiol valerate since long. Abbott has introduced estradiol hemihydrate also. The claim is hemihydrate is a better salt, so it undergoes, it produces less liver toxicity or side effects on the liver. But for practical purposes, I think as we are using estradiol valerate since so long, I am using it personally for, of course, I am also using Estabet also. Maybe I am trying it in some patients where the estradiol valerate doesn't work. But I think more or less, the salt will not make much of a difference, because what we want here is the 17-beta estradiol. That is the active compound which induces the transcription process, which induces the mRNA, which induces the endometrial proliferation. So the active compound is 17-beta estradiol in all these preparations. The salt, of course, it may be some side effects here and there, but I don't think, actually you have got so much of experience. Have you ever found any patient on Provinova having some liver problems, or maybe going for iatrogenic, some maybe hyperbilirubinemia, etc.? I don't think so. So more or less, I think these are all good enough products. So it's your personal choice and your personal listing. I have been using estradiol valerate, but I think, and there are so many companies who have come into this, but I think you have to go for a molecule which is sustained the test of time, because the molecular purity is very important. Like Dr. Velankar said, the endometrial preparation is the most important, because it has to be prepared in the best possible way. The endometrial factor per se intrinsic we cannot change, but at least giving the drugs, the purest drugs in the most correct fashion is more important, which we always control. So I think more or less it doesn't matter. Like,
Milind, what are the doses which you used and normal induction ovulation, and what is the route?
Madam, actually for ovulation induction, like we always know, we start with 50 or 100 cc is our drug of choice. The clomiphene citrate we use. I think if you do an ultrasound on when the follicle is dominant, maybe for clomiphene we take it between 18 to 20. There are a lot of studies which say you trigger a little bit late, even for IVF, except for the antagonist protocol. So if you trigger between 19 to 20 follicle, you have a better quality oocyte, better M2, you have a better embryogenesis, you have a better, in short, you have a better pregnancy rate. So always target for the trigger between 19 to 20 follicle. If at that time you have an endometrium of 6 you need not wait, because the follicle will be post-mature. You go for the trigger, because we should think the endometrium 6 is on the day of trigger. You are going to give a trigger. After 36 hours, you will have ovulation. Then you will have fertilization. Then you will have the morula. You have the day 3 embryo, day 5 embryo. So by the time the embryo implants, it will be nearly 7 days after the trigger. So always think in that terms. After 7 days, what will be your endometrium? Not on the day of trigger, because on the day of trigger, the embryo is not going to implant. Even the ovulation, the oocyte is also not released. So if you project it that way, even 6 endometrium on the day of trigger is fine enough. And if you feel 6 is less, if you want, you can always supplement with estradiol valerate. Studies have shown that supplementing estradiol valerate does not interfere with folliculogenesis or the ovulation. But I'll tell you personally, you always see what causes the LH surge is high doses of estrogen. When the follicle grows, you have endogenous estrogen increasing. Endogenous estrogen is responsible for the LH surge, which is responsible for the ovulation. So I personally feel if you start high dose of estrogen early, around maybe 14, 15, 16 there is a chance that you may be inducing a premature LH surge by giving high doses of estrogens. So I feel that more simpler is a better. 6 endometrium is good enough. You continue with the cycle. You go, if patient gets pregnant, fine. If she doesn't get pregnant, maybe you can try changing the stimulation, the oral ovulation which you are using. Maybe you can go in for a letrozole, which is of course the drug of choice, especially in PCO, or when you have a clomiphene resistant or clomiphene failure patients, or even you can try with tamoxifen. I would prefer letrozole as a drug of choice first year.
Okay, thank you.
Second
And route is
question.
oral. Route is
Yes.
oral. Oral route.
Oh yes, you can use vaginal also, ma'am. Actually, you can use vaginal also, because I have found, actually I did this test. I took proguanil, put it in water, because in India, there is no vaginal preparation which can be given transvaginally. When I was in US, I spoke with that ASM president. So they were using vaginal progesterone. So I tried this. When you put a proguanil tablet in a drop of water, you see it starts dissolving very fast. Other preparations, I will not mention, they don't dissolve that fast. And these are all sugar coated. So when you are using a sugar-coated medicine in the vagina, you have to be careful, because it may induce maybe fungal infection or any other infection. But proguanil that way is safe, it dissolves very faster, and you have a better endometrial tissue levels of estrogen there. So sometimes it may happen that maybe her absorption is not proper, maybe her GI is not proper. We have so much of malabsorption syndrome. In India, infectious diseases are so common. So maybe you can try a vaginal route. So maybe you can have a better endometrial preparation there. And if that doesn't work, even you can try a transdermal route also. Estrogel is also fine enough. You can use estrogel also. That is also good enough. So always try to think and always try to change the route, right? Because sometimes it's a body. So we cannot say that one system is working, it will work in the same for the other person. So we need to think proactively and apply accordingly.
Thank you.
The second question
May I ask?
is, one more question, sir.
Yes.
Sir, what is your dose of GCSF and root for thin endometrium?
Actually, we use 300 microgram. No? The single ampule we used to use.
No, but you use intrauterine or subcutaneous?
Yes. Intrauterine. Now I've stopped using GSSF. I have a lot of friends in Mumbai. Many of the Mumbaites, they do regular GSF for all patients. I don't do it. And if you see at the evidence in literature, there's no evidence as such. Many of them use it subcutaneous also, especially for recurrent pregnancy losses. I think you're using it subcutaneously.
Yeah.
For recurrent pregnancy losses. Yes, I know.
Subcutaneous has been shown to have some benefit. Intrauterine has not shown.
Exactly. I did try, madam. Actually, we as an endemic, this is an endemic country, so we have such a lot of subclinical infections. I used to get a lot of thin endometrium. So I was really, so I got those tubes for PRP preparation from the US. That was way back 4 years back. But ultimately, I came down with the ACDA solution, aspirating in vacuum trainers, doing that ACDA solution preparation, centrifuging it, discarding then the plasma, platelet poor plasma, platelet rich plasma, again recentrifuging it. I did all those, madam, and activating, of course, with the calcium. And I used to do it. Like I used to do it maybe 4-6 days before the eating. I used to do one installation, then wait for 48 hours at least, do an ultrasound, see how is the endometrium, the morphology, the thickness. If I found it's not satisfying, maybe we can go in for a second installation and again wait for 2-3 days, means 48 to 72 hours, and then go for the ET. I did get pregnancies also, I did not get pregnancies also, but overall I think rather than just looking at the endometrium, the thickness and the morphology, what is important is after you do such an intervention, whether it increases your pregnancy rates and more ultimately, whether it increases your live birth rate, because that is all what we are aiming for. And I don't think there is any statistical difference in the live birth rates.
Yeah, still I think lots of studies need to be done, but
Yes,
there is a lot of enthusiasm at the moment for PR and intrauterine PRP, and I also like to do it. Means I have not discarded the procedure yet, and still we need to have more studies on it and more evidence on it. But there is a lot of enthusiasm worldwide about use of the PRP.
Only two things to add, madam, here. First is in an endemic country like India, compared to the Europeans, the Caucasians population or this the US population, we have a lot of infections. Maybe it's subclinical, which may not detect it in non-conventional modalities like hysteroscopies or this thing. Maybe it's subclinical. Then these tend to have thin endometrium. And then we get stuck. And then we start feeling, no, I have to do something for the patient. And then we start thinking. Like,
for that, I think few tests have come up like Emma and Alice. So those tests may have some future because they will tell us about, and maybe these microbiomes is a new thing that is coming up and that may give us more insight into it. So at the moment, we are not very sure. But yes, there is a lot of enthusiasm about PRP. So I think we cannot just discard it yet. Let's wait for the proper evidence.
Yes.
Basically, this GSF, when it came with a very attractive name of endometrial glue. And many of the ART consultants then started, getting attracted towards it. But eventually everyone realized there are certain limitations to it. Milind, it was really wonderful presentation. I want to ask you one more question.
Yes.
Have you ever during practice noticed that sometimes, especially in the frozen embryo transfer, the endometrium becomes a little more thick quite early? Then how you manage those actually cases? Like you
actually,
want to go 9 millimeter, but sometimes it happens, it goes to 10. And then what is your actually the intervention actually strategies here?
When you mean to say you do this is with down regulation or without down regulation?
No, in the FET cycles.
No, but in FET cycle, you have either with down regulation or without down regulation.
Yeah, both ways you can tell whether you're down regulated or whether you are given Leuproid.
Personally, I have got a Meditech software. So anything, whatever I'm doing to my patients, right from the demographics of the husband, wife, till their what dose they receive, how much embryos they made, how was the freezing vitrification. I have everything single shot I can see. So I have seen in all patients, if you do a normal HRT or you do a normal stimulation, the endometrium will always be higher, maybe 2 or 3 mm higher than when you do an FET. And especially when you do with a down-regulated FET, because the very reason is when we give a agonist, especially in Indian women, where demographically they're not that, the skeleton is not that big. So I think 3.75 milligram of intramuscular depot sometimes takes a toll. The endogenous estradiol levels drop to a very low level.
Yes.
So many times when I do a normal HRT without down regulation, the endometrium is good. I take them for FET, I down regulate, and then when I stimulate them, I find that the endometrium is not going. That is because whatever the little endogenous endometrium estradiol was helping for the endometrium to grow, here we have cropped that. We have down-regulated them severely. So they are only entirely depending upon the exogenous estrogen for the endometrial development. So many times in the FET cycle, we find the endometrium more thinner. That's why you must have noted if fresh cycle, the cutoff is 8 mm for thin endometrium, and for the FET cycle, it's the 7 mm. The point is because endometrium in FET cycle will always be a thinner side because many of the patients are down regulated, and then without endogenous estradiol helping the exogenous estradiol to develop the endometrium, these go down on these levels.
So it is best. So it is best to go for either natural cycle frozen embryo transfer.
No,
or
you can go without down regulation. You can go without down regulation.
Or letrozole induced HRT, because the studies have shown that the HRT cycles, they are associated with more pregnancy complications like adherent placenta syndrome as compared to the frozen embryo transfer in a natural cycle or in letrozole induced cycle. So worldwide now people are trying. In certain situations you can't avoid and you have to give HRT, but now people are thinking about trying to avoid HRT, and there are some people who feel that corpus luteum, the natural corpus luteum, is very helpful for the continuation of normal pregnancy, so why not utilize it best? So these are the new things that are coming up.
Only thing is when the patient is of a oocyte recipient, she also herself is very low on the ovarian reserve. So letrozole or any ovulation induction will only work when the woman herself has some ovarian reserve.
Yes.
When we are going for an embryo donation, when we are going for a oocyte donation.
Yes, true.
We don't expect
the situations where you can, you should. Yes.
Correct. Otherwise, madam, there's one more option we can do is we can we will not down-regulate the patient. We can directly take, once she has menses, you start HRT. If you start HRT early and if you start with high doses of estrogen, exactly, the FSH will not increase because we are adding estrogen and she will not ovulate. So that is also a good option. I think, Milind Shah sir, I have answered your question, or you wanted to say the opposite way. It grows more thicker, you said. So sometimes it happens that you start the estrogen and the endometrium is thick, right? And you still have time to do an embryo transfer. I think you don't increase the dose, you continue with the same dose of estrogen. Giving estrogen for a longer period will not harm in any way the endometrial receptivity. And whenever your date or the time or the batch date comes, you can always start. More important is the timing of progesterone. Estrogen 1 week plus minus doesn't matter at all. So you can always hold the dose, don't increase the dose, because already if you think the endometrium has reached the optimal levels, you hold the dose at what levels you are giving. And then once your batch is coming, that time you can start the progesterone and time your embryo transfer accordingly.
Correct. Yeah. Good.
Yeah, Milind, can I just add a few things here?
Yes, sir.
Yes.
I think a clear message should go that if the cycle is clomiphene induced, okay, if the thin endometrium is there, probably it is the clomiphene-cited toxicity that has caused the endometrium thin. And adding estrogen to these patients may not help. One thing. Second thing, if first cycle we find that clomiphene has caused thin endometrium, some of the pharma companies do promote that with clomiphene citrate, from the last day of the tablet of clomiphene citrate, you start adding estrogen. And as you rightly said, this estrogen would raise the estradiol levels and would bring about premature elation, and hence it's not going to help. So the best thing is, golden rule is we change the protocol. We change the protocol. You switch over either to letrozole, and letrozole also 2.5 milligram, really, it doesn't push the ovary at all. We have to use either 5 milligram or 7.5. Or letrozole plus gonadotropin of your choice can be added, one thing. And what Milind was saying, as if sometimes we get thick endometrium, I think, Milind, if we are planning embryo transfer, say after 10 days, if you have started estrogen therapy today in whatever the dose, either 4 milligram or 6 milligram, whatever your protocol is, what we practice here is we call the patient on day 7 to assess the endometrium. And if on day 7 we feel the endometrium related to two things, we increase the dose of estrogen. And if we find that the endometrium is growing pretty well, and by the time probably it would cross 15 millimeter, 1.5 plus endometrium is no good for implantation. We all know that. In that case, we can curb upon the dose of estrogen which we have started. And if at all you are scared about the complications of estrogen therapy, because we can quite often get a call from the neurophysicians regarding this patient was taking OC pills and this patient was on estrogen therapy and she had landed with this problem. In that case, I think using transcutaneous application of the gel is much safer for the patient as compared to these tablets, but it all depends upon what you are used to. Thank you very much.
Good.
And sir, fortunately in India, inherited thrombophilias, which are the more dangerous or predisposing factor for all these coagulopathies, is quite uncommon compared to Caucasians.
Hello.
Thank you, Milind, sir. It was a wonderful presentation and healthy discussion. Now we'll move to the next session. Thank you so much.
Yeah.
Thank you. Thank you so much.
Thank you, Dr. Milind. I congratulate Milind Patil. I congratulate you for having very nice success rate in ET, more than 86% up to 88% in the whole last decade since 2011, and wish you the same great success in future also. Thank you very much.
Thank you.
Let us move for the second lecture. May I invite chairpersons Dr. Sulbha Zambre and Dr. Lata Agrawal, madam. Dr. Sulbha Zambre, she is senior consultant in Zambre Nursing Home since last 35 years. She is past president of Solapur OBGYN Society. She is ex-lecturer in VMGMC Medical College and Railway Hospital. Madam has great contributions to various conferences organized in Solapur and very enthusiastic and quite bold personality and one of the busiest private practitioner. Welcome, Sulbha Zamre, madam. Dr. Lata Agrawal, madam. She is at present president of Pusat Obstetrics and Gynecological Society. She has completed her MBBS and MD from Government Medical College in Nagpur. She is practicing in Pusat since last 23 years. At present, director of Medicare Multispeciality Hospital, Pusat. Welcome, Lata Agrawal, madam.
Thank you.
We are having lecture on ovarian reserve by Dr. Rajiv Dabde. Hand over to chairpersons now.
Hello. Hello, good morning to everybody. Now we have a second lecture of the seminar. First lecture was excellent by Dr. Milind Patil. Now second we are with the Dr. Rajiv Dabde. I have to introduce him as a what I should say, that my junior colleague, very enthusiastic, cooperative, and very helping colleague. He's a good endoscopic surgeon, and overall he's a very good human being. Very popular teacher, attached to the Ashwini Rural Medical College as a professor, and the students are very fond of this teacher, and he also loves teaching very much. He has delivered many lectures in different conferences. He was an instrumental in organizing a most conference in Solapur, and he is the director and endoscopic surgeon and IVF consultant, practicing since last 30 years, and special interest in fertility. Is the director of the Navjeevan Fertility and IVF Center, Solapur. Now he will be delivering us the lecture on ovarian reserve. As we know, the ovarian reserve, the quality and the quantity of it tells us about the quantity and the quality of the ovarian primordial follicles, and it reflects the fertility of the particular female. Now he's going to throw us and tell us more detail about ovarian reserve and guide us for further. Dr. Rajiv Dabde, please.
Thank you, madam. Thank you for those kind words. Can I start sharing my screen?
Yes, Raju.
Yes, sir. Please share your screen.
Something went wrong. Sorry.
You can see the
Yes,
slide.
we can. Yeah, we can see
You
this.
can see the slide, Raju.
Yeah, you can see, but I'm not able to see them.
Slides are on the screen.
You can put cursor on the slideshow.
Yeah, now share this. Yeah. Something has gone grossly wrong. I'm sorry for this.
One thing, there is one icon below as we put it for the slideshow. You put on that, and I think it should work.
Is it okay now?
We can see the slide.
Fine, fine.
Yes,
So this is the first slide of Ovarian Reserve. I thank EVA Division of MQR and Bakshi Madam and Solapur OBGY Society for giving me this opportunity. I hope I am audible.
Yes.
Thank you so much.
Yes.
Not visible, but
yeah. Okay.
Not visible. We can see you. Cannot see you. Your slides
are not visible.
Amit, you see that we cannot see Dr. Dabde on the screen.
Yes, sir. Now we can see.
Okay,
yes,
thank you so much.
Yes,
okay,
yes.
Okay. So why at all we should be assessing ovarian cancer? Age is considered to be important indicator of ovarian reserve, but this is a big but there is a considerable individual variation in the age of menopause and the age of subfertility. So age is not though it is important, it is not the accurate indicator of reproductive aging and hence of the ovarian reserve, and that's why we need to assess ovarian reserve by some other means. Also in the society, there are changing trends. What are the changing trends? The career-oriented women, they get married late and then they delay their childbearing, decreasing their ovarian reserve. So they should, I do have few patients who really inquired with me as to how much can we delay her wedding. So I said it will depend upon her AMH values. Okay, so if AMH values are really alarming, we can advise the family that get her married fast and let her have children earlier so that she doesn't have to consult the ART specialist. We also have increased incidence of divorces and remarriages. We have childhood cancer survivors, and we have patients seeking reversal of sterilization because some of the mishap with the previous children. And of course, before planning fertility enhancing surgeries, this is the point I want to highlight, that whenever we are doing any surgery, we are touching the ovaries, say for simple ovarian cyst or ovarian endometrium, it is worth doing AMH values before the surgery, because AMH values, if they are low, we can always counsel the family well before doing the surgery that basically her ovarian volume is low, and so that after the surgery, if they still try having pregnancy and they consult somebody else, and when the AMH is done, if it is very low, the patient should not blame our surgery for reducing her ovarian reserve. We also have cases of recurrent pregnancy loss who have low ovarian reserve. Low ovarian reserve is probably the cause of RPL in those patients. So these are the things where this assessment of the ovarian reserve helps, as I said, in proper counseling, in IVF program to decide the dose of gonadotropin to be used, and we can predict the ovarian hyperstimulation syndrome. So control the dose of gonadotropin so that we don't land into this problem. And whenever we can always it is very easy for us to counsel the patient to recruit in the donor oocyte program after we have really done the test for ovarian reserve. We have different markers for ovarian reserve like chronological age, baseline hormones, and ultrasound parameters. Age is very important because fertility rapidly declines after the age of 30. See, when a female child is born, the child is born with billions of primordial follicles in her ovaries, and as the age would advance, the process of apoptosis continues, that is the natural death, and it's a processus continuum. I want to highlight here that the process of apoptosis is a processus continuum because sometimes some patients may have some ideas in their mind that I can take oral contraceptive pills, not ovulate myself so that my ovarian reserve would be conserved. That's not true. Whether it is pregnancy or whether it is patient is put on oral contraceptive pills, the apoptosis process continuum continues decreasing the ovarian reserve. So as the age advances, the process of apoptosis rapidly increases after the age of 30 years. So we find that after the age of 30 years, there is a rapid decline in the ovarian reserve. Then we can use these baseline hormones, either day 2 follicle stimulating hormone or inhibin B or anti-mullin hormone. These are biochemical markers for ovarian reserve. The biophysical marker would be, the best one would be antral follicle count. I know of Dr. Nagore and Dr. Sonal Panchal from Ahmedabad. They rely only and only on ultrasound parameters to assess the ovarian reserve, and they hardly do these biochemical parameters. They have extensive study on this. So for those who are interested, what these dynamic markers are, we can proceed with clomiphene-cited challenge test or exogenous FSH ovarian reserve test or GNRS agonist stimulation test. But with the advent of AMH coming to our help, these tests are no more done. So I skip this slide and go to day 2 follicle stimulating hormone. This is most widely used marker. As the follicle depletion occurs, there is the FSH goes down, there is low E2 levels and inhibin levels. The FSH would rise, and high FSH basal levels would indicate that the ovarian reserve is decreasing. So high basal level of FSH is a strong predictor of cycle cancellation and the number of oocytes retrieved. And day 2 FSH values more than 15 milli-international units per ml means the patient is definitely going to have poor prognosis as far as her fertility potential is concerned. The higher values have more negative predictive value. False positive rate is seen in 5% patients. Now, day 2 estimation is difficult in patients who have irregular cycles, because if they have oligomenorrhea, they have to wait for 2 months and 3 months for their menses to occur and the day 2 to come so that their FSH would be estimated. In addition to that, there is intracycle and intra-sample variation in the FSH values, but it is suitable for screening, counseling, and gives us a direction for further diagnostic tests. Day 2 estradiol is also a marker of ovarian reserve, but high estradiol values on day 2 indicate low ovarian reserve when FSH is normal. This indicates inappropriately advanced follicle recruitment. What I mean by that is, few days before the patient starts menstruating, the estradiol values go down, the FSH starts coming, and the patient bleeds. So on day 1 or 2, if the FSH values are high, these FSH values have already started rising before the patient has menstruated. And on day 2, if the FSH value is normal, it is not really normal, it should have been high, because it is this high estradiol which has happened because of this FSH which has already stimulated the granular cells, has brought down the FSH values. So values of estradiol more than 80 picogram per ml on day 2 indicates poor prognosis, though this has little low clinical applicability. Day 2 inhibin, inhibin is directly produced by the developing follicles. Accuracy in normally cycling women is modest. Values less than 45 picogram per ml indicate poor ovarian reserve, but this needs to be interpreted with day 2 FSH, antral follicle count, and estradiol values. And we have to remember that obese women produce lesser inhibin than lean women. So inhibin is only useful as much as FSH and E2 in screening, counseling, and giving us direction for further investigations for ovarian reserve. Antral follicle count is a single best predictor. It should be done by transvaginal probe with a probe of not less than 7.5 megahertz frequency. And those who have this 3D facility, Sono AVC comes to help. With the click of button, we can do the 3D scan of the ovary, and another click of button would enlighten these cystic areas in different colors, and that would give us a pretty near accurate estimation of the antral follicles. Why I insist on transvaginal is, now this is Dr. Bahubali Doshi, who is my guardian, and when he visited Egypt, you can see the pyramids here. So from a distance, we cannot really estimate how big these stones would be, but the closer we go, we can really see how big they are, almost an arm span. And that is why, that is same thing is holds true for transvaginal ultrasound assessment of the ovaries. The closer you go, the better the picture we get. And of course, we have patients with polycystic ovaries with thick stroma. The stroma would be increasing, normal count, and those patients with low antral count. Definitely this antral follicle count, if it is more than 4 or less than 4, has importance in pregnancy rate and cancellation. With good antral follicles, the pregnancy rates are better and cancellation rates are low. With low antral follicle counts, the pregnancy rates are low and cancellation rates are high. Coming to ovarian volume on ultrasound, that's also an important marker. Less than 3 ml is associated with higher cancellation rates, and it has a poor performance as compared to the antral follicle count. Ovarian biopsy. Ovarian result depends on the number of primordial follicles in the cortex. Actually, follicular distribution in the cortex is heterogeneous. I have mentioned here laparoscopists, please note, because we have pictures of patients coming with polycystic ovarian morphology. And sorry, Pandit, this is not applicable to you, I know, but any laparoscopic surgeon would be tempted to put in the needle and cauterize those, go ahead with the drilling procedure. But remember that follicular distribution in the cortex is heterogeneous. What I mean by that is, if the place where we have done the drilling, if it had the highest concentration of the primordial follicles, we are going to markedly deplete this patient of the count of primordial follicles, and hence the ovarian reserve. So this ovarian biopsy, coming back to ovarian biopsy, this is an invasive procedure and can be potentially harmful. There is always a risk of adhesions. So ovarian biopsy is not the way we assess the ovarian reserve, definitely. I will be talking more on this anti-Mullerian hormone. I beg pardon of this august audience if I go to some of the basic concepts of this. Being attached to medical college, I have the habit of taking these lectures. So maybe I will be going to little basics in this. Historical aspect of anti-Mullerian hormone is, at the early stages of development, fetuses of both the sexes have two pairs of ducts, which we all know, the Wolffian and the Mullerian. And it is the Mullerian inhibiting factor which suppresses the growth of this Mullerian duct in the male fetus, and the Wolffian duct grows. So in 1940, Alfred Jost showed that testicular product, which is different from testosterone, was responsible for the regression of Mullerian ducts in the male fetus, and this product was called as hormone inhibitors, which today we call as anti-Mullerian hormone or Mullerian inhibiting substance. This anti-Mullerian hormone is produced by Sertoli cells of the fetal testes. It induces the regression of the Mullerian ducts. In the absence of anti-Mullerian hormone, Mullerian ducts develop into the fallopian tube, uterus, and the upper part of the vagina. This makes us clear this anti-Mullerian hormone is absent in the female fetus in embryonic life. After birth, this sex dimorphic expression pattern is lost, and AMH is also expressed in the granular cells of the growing follicles in the ovary. AMH expression is first observed in granular cells of the primary follicles, and expression is strongest in pre-antral and small antral follicles. Antral follicles we consider as a follicle between 2 to 9 millimeter. So small antral follicles would be responsible for this AMH expression. This AMH expression disappears in the follicles of increasing size and is almost lost in the follicles greater than 8 millimeters. This AMH plays a role in initial recruitment and selection of the dominant follicle. As you can see in this figure, this AMH acts as a brake at two places. AMH is produced by primary and pre-antral follicles in the ovary. It has two sites of actions. It inhibits initial follicle recruitment. In other words, all the primordial follicles would have the growth of this, the growth of this primordial follicle up to the antral follicle, pre-antral follicle is gonadotropin independent. And if all the primordial follicles would get recruited to this stage, and if the AMH was absent, all of them would get converted to antral follicles, and in 1 or 2 cycles, the female would lose all her ovarian reserve. But AMH has an important role in breaking this, in putting a break to this cycle. So I continue. AMH is produced by the primary and pre-antral follicles in the ovary. It has two sites of action. One, it inhibits initial follicle recruitment, and second, it inhibits FSH dependent growth and selection of pre-antral and small antral follicles. AMH acts as a brake in the activation of primordial follicles and the growth of pre-antral follicles. These are earlier we used to get these AMH values in picomoles, but nowadays we are getting in nanograms per ml, and 2 to 3.8 would be optimum fertility in these patients. AMH levels show reduction throughout the reproductive life, and it becomes undetectable after spontaneous menopause. One single measurement of AMH seems to be sufficient. AMH can be measured independently of the day of the menstrual cycle, so we need not wait for day 2 as for FSH or estradiol assessment. And AMH acts as a paracrine rather than a systemic factor. In conditions where FSH levels are suppressed, such as pregnancy, AMH levels remain constant. They are not influenced by the gonadotropic status, and circulating AMH is exclusively of ovarian origin. Measurement at 3-year intervals revealed that AMH levels decline significantly, whereas serum levels of FSH and inulin B and antral follicle count do not change during this interval. By that I mean, this AMH predicts ovarian reserve earlier than the other parameters of other markers like FSH, inhibin B or AFC 3 years earlier. So we can have normal FSH and normal antral count, but AMH would be low. AMH would give you a strong signal 3 years before the patient loses her potential to develop good quality oocytes. The quantitative aspect of ovarian aging is reflected by a decline in the size of primordial follicle pool, and direct measurement of the primordial pool is actually impossible. However, the number of primordial follicles is indirectly reflected by the number of growing follicles. So changes in AMH levels occur relatively early with ovarian aging. Substantially elevated serum levels of FSH are not found until cycles have already become irregular. So if the patient reports to us with either the cycle irregular, the cycles would become initially as the patient is en route menopause. Because of the rising FSH level, there is earlier recruitment of the follicles, and patients will come with polymenorrhea and they will have higher FSH levels. But if the FSH levels are normal and the cycles are regular, still we can have low AMH levels. Now, what do I do for these patients with low AMH levels or those with low ovarian reserve? As you can see, this is a very famous novel in Marathi, Yayati. Here, Yayati was a king, and being king, he had a free privilege to have many queens. Now, because of the curse, when Yayati becomes old with only one blessing, that he can exchange that his old age with the youth of one of his sons. And one of his sons, Puru, agrees to that, and he takes Yayati's old age and transfers his youth to him, and then Yayati gives all his kingdom, makes all his kingdom in the name of Puru, one of his sons. But it's not that easy here in 21st century. So we have to increase the response of the ovaries by pre-treatment with androgen. So patients with low AMH, we can increase their response to the ovulation inducing drugs by adding DHEA this DHEA influences ovarian follicular growth by acting as metabolic precursor for steroid production. For ages, we are considering that it is the oocyte at fault. It is not the oocyte at the fault. It is the environment in which the oocytes are growing are at fault. They make the oocyte to perform poorly. So by adding DHA, we improve this environment and maybe we get good follicles. Continuing the discussion, by serving as ligands for androgen receptors or by other non-classical mechanisms, DHA influences the ovarian follicular growth. DHA is also known to promote follicular recruitment and increase insulin-like growth factor in the primate ovary. Androgens also have been reported to suppress apoptosis. Pre-treatment with OC pills and corticosteroids has not proved to be very useful as compared to pre-treatment with DHEA. Growth hormone may enhance steroidogenesis and oocyte maturation by local production of IGF-1 and supplementation with L-arginine. The rationale here is the role of nitric oxide derived from L-arginine enhances pre-ovulatory local vasodilation, but the dose should be 16 grams per day. This article also says the same thing what I have talked till now. So the last slide, take home message from this talk should be ovarian tests have a reasonable predictive value. There is always a disparity between biophysical and biochemical markers. The quantitative and not qualitative estimation of the ovarian reserve and should be used for counseling the patient, should not be used to deny the treatment. It is more effective in combination. I mean, biophysical and biochemical, if taken together, are more effective in coming to decision. Response to first cycle still remains the best predictor of ovarian reserve than to any stimulation protocol than any ovarian reserve test. So this should be renamed as ovarian response test rather than ovarian reserve test. I thank you all for your patience. Thank you very much.
Thank you, sir.
A question, can I ask one question?
Yes, madam.
What are the level of FSH D2? You will say that this is a low ovarian reserve. What will the
yes.
level?
If FSH is more than 1.5 and E2 is more than 8.0, 50.
8.0. But
Yeah.
few of your slides said the estriol at the low level.
No, no. What happens with low ovarian reserve is the levels may go low. But what happens that is before actually, I mean this FSH, the FSH should always be interpreted in relation to E2 levels. FSH alone should not be interpreted. We have few of the experiences like patients with polycystic ovarian syndrome, they anyway have oligomelia, and before this advent of AMH, when we used to call them, you come on day 2 to test for your ovarian reserve, they used to come to us saying that I still have not had a menses. And then when we estimated their FSH values, they were too low. Too low FSH values gave us a thought that this is something not really explainable for these patients. When we got their E2 levels done, these E2 levels were pretty high. And when we got their urine pregnancy test, that was positive. So what I mean to say that FSH is E2 dependent. Okay. FSH is suppressed by the negative feedback mechanism of the estrogen levels. That's why it must be interpreted only with the E2 levels done on the same day, not alone. FSH not alone.
Then should we do both? FSH as well as estriol?
Then do AMH, that's the best thing. And correlate that with your transvaginal antral follicle count. That is the best. Yeah.
Okay. Hello. Bahubali Doshi sir has raised hand. Sir, can you talk, sir? Bahubali sir, unmute yourself.
Unmute him.
I'll unmute him. Sir, please unmute yourself. I will send a request to you.
Yes. When I was listening to, am I audible?
Yes, sir.
Yeah. When I was listening to the talk, I just wanted to add a couple of things. I mean, just to highlight one more thing. The slide which was shown about AMH, and it acts as a brake. So the simile which we want to give is, see, in our childhood, we used to play the slide, घसरगुंडी. आणि जोरात घसरू नये म्हणून आपण दोन्ही बाजूनी हात घट्ट धरून सावकाश खाली येतो. That is how the AMH acts. It doesn't allow the primordial follicles to grow. At the same time, I mean, it controls on this side, and it doesn't allow many more follicles to be recruited. This is one. And as about Dr. Zamre's question, E2 and FSH.
Yes.
Whenever the E2 is high, the FSH is going to be low.
Right.
Sometimes what happens when we estimate the FSH on day 2, the patient have come. Hello?
Yes.
Yes, you are audible. Please continue.
Yeah. The patients come with withdrawal because they have a irregular cycle. So their previous consultant or the general practitioner has given them withdrawal, OC pills for withdrawal, and these patients will definitely have a low or normal FSH, and so there is a chance that we will miss the patients with high FSH. So if you are doing an FSH, then E2 has to be done simultaneously.
E2 has to be done, or FSH has to be done on day 2 of a spontaneous cycle.
Spontaneous
and
cycle.
After OC withdrawal. Yeah.
Yes.
Okay.
Thank you.
Can I add one thing? Hello?
Please.
Yes. Actually, but at around 35 to 36 years of age, especially in Indian women, there are many studies which have compared this Spanish counterparts with our Indian counterparts. And it has been proved that Indian women age really faster. Yes. In fact, they age 6 years faster than the Spanish counterparts. In essence, what it means is, if we have an AMH, a particular AMH.
Yeah, I think we are not audible.
You are not audible.
Not audible.
Yeah, but what it means to say, as according to Western literature, the age of menopause is 52 years, but for Indian women, it is 46, 47 years. That is a rapid depletion of the follicles takes place in Indian women. So Indian obstetricians and gynecologists should start treating patients with infertility after assessing their ovarian reserve at an earlier age.
One last thing, can I add?
Yes, please.
Say, when I started this infertility practice, I used to find or see more and more cases of polycystic ovary syndrome. But let me tell you, we have more infertility problems with a low ovarian reserve than a polycystic ovary syndrome. Any patient coming with just irregular cycles and sometimes she is obese, these patients are put on metformin and then treated as if a case of polycystic ovary. Unfortunately, without looking at the ovaries on day 2, majority of the people, they say, the patients are also embarrassed and the doctors are also embarrassed to examine them on day 2. Any infertility practice cannot be completed or even started without doing a day 2 scan. That's what I want to add.
Yes, sir. I just missed on that point that DHEAS should be exclusively reserved for patients with poor ovarian reserve, and that too it should be given for good 3 to 4 months. You will give this tablet to the patient. Earlier it was available as 25 milligram 3 times a day, but now we have sustained release preparations of 75 milligram once a day. Just tell them to take this for 3 to 4 months and forget about it. Okay. Many of the patients would come to us with conception. Only thing is that as and when the pregnancy is confirmed, they should immediately stop this. It is an androgenic effect, one. And sometimes the patients with polycystic ovaries, if they do not ovulate, we've seen some prescriptions that probably thinking that this patient is not ovulating because her intra-ovarian environment may not be suitable for that, and these patients have been put on DHEAS, and DHEAS increasing the androgenicity of these patients is going to worsen the ovarian status as far as potential is concerned. Thank you very much.
So I would like to add one point, sir. Like I have my video got disconnected. Key first thing is about 35 to 36 years of age, our Indian women start losing their reserve. And then what happens in their menstrual cyclicity is they start having shorter duration of cycle. The cycle length starts reducing. So if we observe keenly in our practice, the cycle length will be about 25 to 27 days of a woman who is starting aging. So even sometimes clinical parameters also help. But I feel rather than doing a day 2 FSH and E2, it is always better. Do I know AMH is a bit costly, but AMH is the gold standard in assessing ovarian reserve. So that is one point. Secondly is now the recent evidence is suggesting that DHEAS doesn't help much in doing improving the pregnancy rates in this poor ovarian reserve patients. Yes, testosterone may have a role. Of course, the early studies are suggesting some beneficial effect of testosterone. So what are you doing now?
Yes, we add testosterone just 15 days before the patient is taken for stimulation, not 3 to 4 months as we have been giving DHEAS. One more point I just wanted to tell about AMH. AMH may not always correlate with your ultrasound assessment of antral follicle counts. What happened is when we initially started using this AMH, many times we used to have AMH either high or low, and we used to write on our paper that this AMH does not correlate with the antral follicle count. And then there was a question before us as to what we should be doing. Should we be relying on AMH or should we be relying on antral follicle count? Okay, then actually myself, Girish Kumtekar and Bahubali, we went to Mumbai. We went to one of the most standard lab which were doing this AMH, because we always think that our person is not doing the good job. Okay, so we just wanted to know from that lab as to what they are doing, and we really, of course, that laboratory person was also impressed that people from Solapur have come to see how I am doing AMH, and then we realized it's the same way that our pathologist is doing. Okay, and then we said sorry to our pathologist, and we told him that yes, your results are correct. Okay. And because we didn't have much knowledge at that time, and then as we read the literature, we came to know that AMH may not correlate with your ultrasound findings. Okay, so we may, but AMH should be relied more upon, because we can have polycystic ovarian picture with normal or low AMH. Okay, this polycystic ovarian morphology is different from polycystic ovarian syndrome, which is to be well understood, and unnecessarily the patient should not be taken for drilling. All patients who are to be taken for drilling, all patients who are to be taken for any ovarian surgery, AMH forms the investigation in a pre-operative profile. Okay, only when the AMH is high would the drilling help in these patients. Otherwise, these patients would unnecessarily have to go ahead for a donor oocyte program. Thank you very much.
My question is for Dr. Milli. What is your experience of serum AMH?
No,
Kalyan, we can't listen to you. Kalyan,
Raju, yeah, can I add one more point in this?
Yes, please.
Yeah. See, Raju,
yes,
in this particular cases where you are saying the morphology is PCO type, but AMH is low or it is normal, naturally we look at the ovarian stroma basically in the morphology part of it, because which is more diagnostic. But quite often when you suspect actually PCO, suppose AMH is very high, it is more than 10. So that also gives us clue to be little more careful about the OHSS as well. So what do you say on that?
Yes, we should always be scared about OHSS in stimulating the patients of polycystic ovarian syndrome, undoubtedly.
Correct.
Yes.
Yeah.
So we must always start, if it's an IVF program, we must start with the small dose of gonadotropins. But if we're taking the patient for say IUI or simply ovulatory induction, though letrozole is the drug of choice, whether we use letrozole or clomiphene citrate, these two drugs have not known to bring about OHSS in the patients. OHSS, we should be worried only if we are injecting gonadotropins.
Yeah. Rather, I would always say that, these are the patients, suppose they hyperstimulate, we should counsel the patient before stimulation that we may need to convert the cycle from IUI to IVF as well. So suppose that counseling is done and the patient is affording, that is great, actually the advantage of getting good oocytes and at the same time not losing those oocytes, just subjecting for the IUI.
Kalyan, you are not audible. Kalyan is muted. Actually, when he was talking, his speech was not correct.
Kalyan, unmute yourself. Kalyan.
Now tell him to unmute. And use
Kalyan, now unmute.
Good afternoon, everybody.
Kalyan, take the mic closer to
speaker
your...
seems to have a problem. He has put a question in the chat box.
Yeah, in the chat
what
box.
Is
what
AMH levels in hypo PTS?
Yeah.
Hello. So he has put the question in chat box.
Yeah. It says, what about the hypo actually gonadism? He has written that, yeah.
What is AMH levels in hypo PTS? Rajiv sir, yeah, there is a question from Dr. Kalyan.
Yes, Kalyan wants to say something.
Hello. Can you listen to me? Hello.
Can't hear you well, Kalyan.
That's fine.
So he has put the question in the chat box. You can answer.
Okay. Yeah. I got the question. Yeah. See, see this hypogonadotropic hypogonadism itself means that the primordial follicle pool in these patients is very low. Okay, so the pre-antral and small antral will be low. Okay, so these patients will have low AMH.
Yeah.
Kiran madam, we have to take more questions.
Yes, let us go. I think we should move forward now.
Yeah, you can conclude now.
One more addition.
Yeah, Lata madam, please give concluding remarks now.
Good afternoon all. I think it is my first of all my privilege and honor to have to sit with such a distinguished and intellectual guest. Thank you as Solapur Society and Bakshi madam for giving me this opportunity. And Rajiv Dabre sir, you are fantastic. You are a good teacher, very good teacher. AMH simplified so well. And I think the ovarian reserve is now banged in our brains forever. And I think nothing much to say after such an interactive session. I just wanted to add like his style only. We have the oldest mother of Mother Mangayam of 74 because of ART, irrespective of her ovarian reserve. So ART has done wonders. And also the most prolific mother up till now in world is Mrs. Fedor Vasile of Russia, who has delivered 69 children. Out of the 16 pairs of twins, 7 sets of triplets and 4 sets of quadruplets. And 67 of them survived. This was way back in 70s, 1750s, 1760s. So, sir, human body is wonderful and science is doing wonders. Thank you very much, sir, for updating us in such a nice way, such a difficult topic, simplified very well. Thank you, sir, and thank you all.
Thank you, Lata Agrawal madam and Sulbha Sambre madam. Now, may I request our Vice President, Dr. Aboli Velankar, to introduce the experts for the next session where we are having expert discussion.
Hello.
Yes, you are audible, Aboli.
Am I audible?
Yes.
Yeah.
Now we are going to start our next session. This is the expert discussion on, is ART pregnancy a high-risk pregnancy? For this discussion, I call upon the experts Now the first expert is Dr. Asha Bakshi. She is a director, Disha Fertility and Surgical Center, Indore, and a leading consultant at Dr. Asha Bakshi Fertility Center in association with Motherhood Hospital, Indore. She is a joint secretary ISAR in 2021. She is a founder, chairperson, MP IAGE and MP ISAR. She is a chairperson of Foxy Infertility Committee from 2017 to 2019 and past president of IOGS. To her credit go the first ICSI, Tessa ICSI and Micro Tessa ICSI babies of MP. Wonderful, madam. She is the recipient of Dr. Kumud Tamaskar Award Foxy 2008 and 2009 and the best paper Foxy Journal 2011-2010. She runs the Foxy recognized infertility and endoscopy courses and certificate courses in ICOG in infertility and endoscopy. She has organized many conferences like Star Endogyne 2019 and joint organizing secretary of IFFS 2016. She is contesting for the post of Vice President West Zone Foxy. Welcome, Asha Bakshi, madam.
Thank you very much, Dr. Aboli, for the kind introduction.
Our second expert is Dr. Kalyan Barmade. He's a gynecologic and endoscopic surgeon and IVF infertility specialist. He is chairman Latur Fertility Center Private Limited, Baramde Hospital, Latur, Maharashtra. He is a managing committee member of IAG 17 to 20, chairperson of Public Awareness Committee, Foxy, President Latur Obstetric Gynec Society 2021, President Latur IMA AMS 2021. He has organized conferences at Latur and Aurangabad as organizing secretary. He has, in 2009, he has passed MRCOG and he has regional conference at Latur. In 2017, first UR IAGE conference at Latur, 18 Endo World IAGE conference at Aurangabad, and 19 Sonocon Foxy National Conference at Aurangabad. He has been invited as operating faculty and guest speaker at national and international conferences all over India and abroad too. I welcome Dr. Kalyan Barmade. Our third expert, he needs no introduction, is Dr. Milind Shah. He is a well-known obstetrician and gynecologist in Solapur and has specialization almost in every field of obstetric and gynec. He was President ISOPAB 1618, Deputy Secretary General FAOPS, Asia Oceanic Federation of Perinatology, Vice President Foxy 2011, Joint Treasurer ISPAT 1719, Ex-Chairman Rural Obstetric Committee Foxy, and Managing Committee member of Steering Committee member, Professor HOD Department Obstetric Gynec at Gandhinatha Medical College. He is a national editor member for Foxy website. I welcome Dr. Milind Shah for this.
Yeah. Thank you very much, Aboli. Thank you very much, Aboli, for your kind introduction to all of us. And Asha and Kalyan, it's really great to have you today for this SOX webinar. I welcome you all, and we extend our wholehearted support for both your candidature. Asha, you are contesting for Vice President West Zone, we know that. And Kalyan, you as well, you are contesting for the Treasurer of IG. We definitely wish you all the best, and I'm very sure all of you will win with flying colors. So I will hand over now to Asha to start the discussion on ART pregnancies.
Thank you very much, Dr. Aboli, for such a kind introduction. And I'm really, really helpful to Dr. Milind Shah for helping me organize this webinar. And thanks to the whole Solapur Obstetric Gynae Society and the nearby societies. I'm thankful to the chairpersons, Dr. Pandit Palaskar, Dr. Sulbha, Dr. Lata Agrawal, and the speakers before Dr. Milind and Dr. Rajiv have really done a wonderful job. Very crisp talks from their own experience and highly impressed. And today now we are going to talk about, we are going to have a sort of discussion on ART pregnancies. Are they always high risk? And this is a case-based discussion. And today the main experts are Dr. Milind Shah and Dr. Kalyan Varmade. And let's stump them well. So friends, you all would agree with me that ART pregnancies are having potential of maternal and perinatal complications, and they can be sometimes dangerous and life-threatening. And what is the role of reproductive medicine clinician? Predict the complications, prevent the complications, and very, very important to pass the details of ART procedures to the consultant, obstetrician consultant who is going to look after the patients so that we can do further care. Now, why these pregnancies are at high risk, we know by the time these patients come to us, they are elderly, they may be having comorbidities, the cause of subfertility itself may be a problem, use so many drugs for ovarian stimulation, and the IVF procedure, the things are getting exposed to the ROS and all those things, and there may be lots of previous surgeries, and these all things, they make these cases particularly dangerous. So let's discuss the first case, and this is a case of a patient who has history of unexplained infertility, married for 7 years, IUI for 3 times, 1 missed abortion. So I think what I'll do is first case I will discuss with Dr. Milind Shah, second case I will discuss with Dr. Kalyan. So the first case, Dr. Milind Shah, this patient underwent IVF with transfer of 3 grade 2 embryos. Do you think this indication is right for IVF?
Yeah, very wonderful scenario, Dr. Asha. We all understand that, whenever we do infertility treatment, especially those who are working as a routine OBGYN, they should have some sort of limit on the induction of ovulation process, as well as the IUI actually cycles. And that's why once you are done with not more than 6 cycles, it's always better to subject those patients either to the infertility specialist or go for the ART if you're doing on your own. Apart from that, there's a lot of social and mental pressure on the patient. So it's good that we should put her actually for the ART procedures. Regarding your second question about free embryo transfer.
Yes.
All said and done, there are many guidelines which keep on telling about single embryo transfer. But practically, we always observe that many IVF centers, they actually transfer 3 or they definitely transfer at least 2 for sure in majority of the IVF cycles. IF2 embryo transfer is always a better policy which keeps us a balance between getting the patient pregnant and avoiding the multiple pregnancies, because multiple pregnancies sometimes may be solicited by patient, but for us it is definitely a complication of our ART procedure. Our aim is always to have a single pregnancy.
We should not transfer so many embryos, and especially if they are good grade embryos. But here these were grade 2 embryos, so there was a question and we got tempted to do something which is not right. And what happens now 12 days later? What does this level ring a bell?
Correct.
This is slightly higher level.
Because
maybe multi-fetal gestation?
Yes. So this is much higher level, and there would be at least twins or maybe triplets also. And look what has happened. This is a transvaginal ultrasound at 6 weeks, and you can see 3 gestation sets. So whenever you talk to the sonologist and he or she says that there are 3 sex, what extra information do you want?
I need to know the chorionicity, whether they are trichorionic or whether they are monochorionic. That is very important.
Exactly. Correct, Kalyan.
Correct.
We want to put a needle into that, so that if needle is kept in a separate sac, then it is fine. If there are sacs are similar, then all fetuses can die. So that is very important.
That's very important. And if you have by chance a set of twins which has got monochorionic and one more is single separate, so which one would you reduce, Kalyan?
I think first I'd like to do sonography, whether I like to see what is the NT status. I'll do it the procedure at around 10 to 11 weeks of gestation. Those who are away from the placenta, then I like to see whether then if there are 3 and one is in a separate, then it's better to keep that separate one alive, ma'am.
Correct. So if there are the monochorionic ones, so you'll inject in one of those. The second one usually gets absorbed, and the third one remains intact. So that would be the policy.
Exactly.
And reduction of triplets to twins or triplets to singleton, again, it depends. Most of the people like to do twins. Now, in this patient, aspirin was stopped 5 days prior to fetal reduction, and at 10 weeks, fetal reduction was done. So what is your take on this, Kalyan?
I think better to stop aspirin 3 to 4 days prior. And also if this patient is on low molecular heparin, I like to stop that minimum 48 hours prior to the surgery. And this fetal reduction was done at 10 weeks. I like to do it at 10 to 11 weeks of gestation.
Very good. Very good.
No problem.
Very good. And you are going to do a transvaginal fetal reduction or a transabdominal fetal reduction?
Ma'am, it is depending on your expertise. So many centers are doing it the transabdominal route, and there are few centers who are doing a transvaginal route, but that is depending on expertise. If I given a choice, I like to do with the transabdominal route, ma'am.
I think most of us are slowly shifting towards transabdominal because that gives us the time to do NT scan, and then we can do, and even it is, you don't have to give GA, the spinal needle is much cheaper and the infection rate is also less. So this is how things are nowadays shifting.
And even the gestational age is slightly now going further. We are now going towards 12 weeks and 11 weeks rather than 10 weeks for the reduction for the obvious reason what you told. Correct.
Yes, Dr. Milind. Now this question particularly is to Dr. Milind Shah. A double marker test at 12 weeks and this patient screened negative. Is there any role of double marker in such cases?
See, the serum markers in the multifetal
patients for prenatal screening?
See, basically what happens, the serum markers have a limited role in the multifetal pregnancy. But there are now actually the softwares whereby we can definitely do the double marker, the dual marker in the twin pregnancies, where they increase actually this mom levels by certain percentage, and they can actually give us certain actually the risk assessment sort of scenario in front of us. But basically what is more important is you rely more on your soft marker and then take help of the serum markers. It may not be that useful as it is more useful in the singleton pregnancy to assess the aneuploidy risk. But in the twin pregnancy, more thrust should be on your ultrasound and the eventually genetic sonogram.
But it may help you a little bit, isn't it? Means it may not be so specific as in case of a singleton, but then at least it may point out to something. And what about the role of NIPS in such patients?
This is again another Now it has actually become a very commonly done procedure, but in twin pregnancy again there is a big question mark because we really don't know the DNA retrieved from that particular maternal blood belongs to which particular twin. And probably in twin pregnancy the amniocentesis would be the better choice than NIPS compared to the singleton pregnancy.
Yes, but if NIPS comes out abnormal, then again it becomes a reason for amniocentesis because you do not know which of the fetus.
Amniocentesis.
Now look what Dr. Kalyan Barmade was saying was correct. We should have done this.
Yeah.
Fetal
And otherwise also in singleton pregnancy, whenever NIPS, yeah. Otherwise also in singleton pregnancy as well, whenever NIPS is actually the positive, we always confirm it with amniocentesis because that is a routine protocol now. But when it is negative, we are very much sure that at least we are not dealing with the aneuploid in that particular case.
Okay.
Yes.
Now, Dr. Barmade was correct because this, in this case, the fetal reduction was done at 10 weeks. But if we had done later, then this situation must not have arisen. Now look, here now two fetuses are left, out of which one has got these defects: nasal bone not seen, ductus venosus. So all sorts of defects are there, which would have not been missed if we had done this after 11 to 13 weeks. So this is a take-home lesson. Now again, another fetal reduction was done on the affected twin at 14 weeks. So now this patient is left only with one fetus. Now because she has already lost two, and she is very much worried that maybe the third fetus may be having some sort of abnormality and she doesn't want this much of torture again. So she wants to go in for amniocentesis. So Dr. Kalyan, what would you say to her? Dr. Kalyan?
Is very right. Her concerns are very right. We should go ahead with amniocentesis at around 16 to 18 weeks of gestation. If amniocentesis is showing that genetically it is a normal fetus, then she should carry on. If there is any abnormality in the genetic amniocentesis, then that can be terminated, ma'am.
Okay, good. Now, she had a target scan which was absolutely normal and a fetal echo was done. So would you like to do fetal echo in all your patients?
Ma'am, these are the ART pregnancies, so it is always better to get fetal echos. If there is slightest doubt that lady is more than 35 years of age, her HbA1c prior was abnormal. If you are use embryo donation for this patient, then I like to go for those patients who are age more than 35 for fetal echo, ma'am.
Okay, so there is no such indication that all ART pregnancies should undergo fetal echo, but in this particular case with so many SLs, I think echocardiography is fairly non-invasive test and it can be done. Now, rest of the antenatal period after this.
Exactly. That is a very correct take-home message, Asha, because because it is non-invasive. Definitely we should include in our actually routine screening because these are the patients who are carrying precious pregnancy. They are not in the category of non-affording and the fetal echo is comparatively approachable to them.
Correct.
So definitely we should think about it. Yeah.
Okay. Yes. Now, after this stormy first half of the pregnancy, her second half goes very well. All the growth scans, Dopplers, everything normal. She's very relaxed now and she says that I want to wait for the natural events. We let her wait for the natural events. And at 39 weeks, we suggest that now we can't wait and we have to at least induce you. So do you think that all ART pregnancies should have cesarean or they can undergo vaginal delivery? Dr. Kalyan?
Ma'am, those all ART pregnancies in my center, I am doing an elective cesarean section until they are multigravida or secondary infertility who has delivered first normally. Second is, it is a choice of the patient per se sometimes, if she's an elderly lady of around say 38 year or 40 year or even 45 year who is undergone an ED cycle or OD cycle, how much we are justified to give a trial of labor for her, and if there is some mishap happening during the labor, then who is answerable to this? So judicially, I feel you should take a decision every time depending on the age, parity, and what is her willingness for going into a normal labor. But as such, I won't go for induction of labor. I'll wait till 40 weeks for spontaneous, because if you are giving a chance, then there's a fair chance of normal delivery for her.
So let's now take Dr. Milind Shah's opinion.
Yeah, see, basically, the factors which were told by Kalyan were very apt, but additional to that, we need to assess her cervical status. It reminds me of a very interesting story where a patient conceived after 14 years of age with IUI donor cycle. And you know what happened actually when I saw her, her head was so deep in the pelvis, cervix was very much favorable, and everyone else suggested relax. So we said, no, we can give you trial, but we should be very vigilant in our surveillance, which we didn't share very uneventful vaginal birth. So one has to individualize. We'll have to see that it's multifactorial, vaginal birth of the cesarean.
The message that I want to give is that ART does not mean cesarean always.
If you are very much confident about your surveillance, and yes. Correct.
So ART does not mean that you have to just do cesarean. If you have got a good team, if you have got good monitoring system, if there are no high risk factors otherwise throughout the pregnancy, then why these women should not be given a chance to deliver vaginally. So please don't think that every ART pregnancy means cesarean. Please use your own acumen, your own monitoring facilities, and then please go ahead. And why should they not be delivered? Even the twins can deliver vaginally. And I particularly am very fond of delivering these patients vaginally because I have a very good team system. So if we can have a good team system, yes, why not? We can go for vaginal delivery.
Yes.
So anyway, this patient had a failed induction. She underwent cesarean and she delivered a healthy female baby of 2.7 kg. Now coming to the next.
Congratulations.
Thank you. Now coming to the next patient, and she is a patient with reduced ovarian reserve, primary subfertility and endometriosis. And she underwent hysteroscopy where she underwent a resection of partial septum, and she had a laparoscopy in which endometriotic spots were fulgurated because there was reduced ovarian reserve and the cysts were very small, so they were just punctured. And then ovarian stimulation was done and we got 7 eggs. And out of those 7 eggs, 1 egg was very large with vacuoles and lots of fragmentation. And rest of the eggs were okay. So IVF or I think ICSI was done, and total 5 embryos were there, out of which 4 embryos were from the normal looking eggs. So those out of that, once she underwent fresh embryo transfer using 2 embryos, then again we did a frozen embryo transfer using 2 embryos. Both the cycles failed. Now we have got only 1 embryo which has reached up to blastocyst stage and has been frozen. And we are under the dilemma because we had left that embryo. We didn't do the day 3 freezing also. We just left, and because it went up to day 5, so we froze it. So now the dilemma is, should we transfer this abnormal looking embryo or not? So who would like to answer amongst both of you?
Ma'am, I'd like to answer.
Yes, Kalyan.
Who are going to blastocyst stage,
yes.
They are naturally selected blastocysts are the best embryos. I'd like to transfer this embryo, ma'am.
You would like to. So we were very much scared and we were not very happy in transferring, but the patient said, no, I want to undergo, please transfer this embryo. I cannot afford to have another cycle. So we transferred, and look here, Dr. Kalyan was absolutely correct. Beta HCG 104, that means the first, she has conceived, first trimester uneventful, but again here, double marker screen positive, PEP-A low. So my question to Dr. Milind Shah is that if double marker is positive, then are you just considering in the terms of aneuploidy, or can you get more information out of this double marker test? Milind?
Yeah, basically we should always take double marker not only for aneuploidy, but additionally it also gives us some prediction about the IUGR as well as the preeclampsia, which we should utilize, especially when we are having this type of scenario, history of infertility and infertility conception. We need to think about the placentation as well, and accordingly we'll have to take the case further.
Yeah,
and
so
whenever this is double marker positive, we should always think of integrated the serum screening, maybe the second trimester. And then otherwise, before that, if the patient is affording, even NIPS would be the better option in this particular case, because that will give again a clue about whether we need to go for the invasive amniocentesis.
Yeah. So I think this is the take-home message, that just don't check that last report that there is no aneuploidy or the risk is that much. Just go through the figures, and if there are low PAPP and low AFP histriol inhibin, it may be associated with placental dysfunction. So in this patient, we have to monitor her closely, inform her about the signs and symptoms, about the fetal movements, about the ruptured membranes, and that because if things are identified early, we can really give a good care and good outcome. She had an amniocentesis that was normal, and look here, at 28 weeks, she presents with premature rupture of membranes, and she was admitted, went home, admitted, monitored. Somehow from 28 weeks, we could take her up to 32 weeks, that is 1 month. And when we did the monitoring, her AFI was only 5 and estimated fetal weight 1.9 kg, but there was brain sparing effect in middle cerebral artery. So naturally, we had no choice but to do cesarean. And this is a systemic review which says that ART pregnancies are associated with more risk of premature rupture of membranes. And ultimately, she underwent cesarean section, 1.9 kg was born. And we were very, very keen on looking at the baby. Is baby normal? Are there any chromosomal abnormalities? Are there in? But thanks God, everything was normal. One of the most beautiful babies. And still the baby comes to us, and we are very, very, very thankful to God for giving us a normal baby. So the gist is that even the abnormal looking embryos can implant, and even the most beautiful looking embryos may not implant. So coming to the third case, and this is a fake case. This is a made-up case.
Yeah.
Made up the story.
Before that, Asha, can I ask you one more question?
Yes.
Yeah,
Yes.
Asha.
Yes.
Hello.
Yes.
Yeah.
Yes. Yes.
So actually, how you look at the newborn screening in this particular scenario? Because now you got a baby which appears very good, no any phenotypical features of the chromosomal aberrations. But do you do routinely newborn screening at
Yes,
your
we
center?
advise when we do the antenatal booking at that particular time only we advise them for newborn screening, because you see I'm trained in England and I delivered in England. So my daughter, who is now 30 years old, at that time also the health visitor came home to do the Hill prick test, and newborn screening was done. So yes, I'm very much in favor of testing every baby for newborn screening, but in UK it is a must for every baby. But here, because the cost is involved, so at least I counsel them the way I counsel every patient for double marker and quadruple. The same way I counsel them for these tests, and if they are ready to take, then the neonatologist further discusses with them and they go for it. Very, very good question.
And then how many analytes you screen for?
Usually, I think
how many analytes?
7, or it all depends on your affording capacity, and the neonatologist herself, she decides that how much, which ones she wants. So I'll leave that to the neonatologist, and we give one leaflet to every patient. So they read, and they also, because most of these patients are educated patients and they understand. And so I think, you are very correct, and you brought a very good point. Now that next case that I'm going to present is a filmy case, a Bollywood story, nothing to do in real life. So this is a surrogate, 35 years old, has history of renal transplant, on immunosuppressant drugs, has average ovarian reserve, and wants to go for surrogacy. So Kalyan Bhai, is this indication right for surrogacy?
No, ma'am, it is not a right indication for surrogacy.
Okay.
If she's really debilitated in disease, she has absent uterus like MRKH, she has significant uterine anomaly like banana uterus, like unicornate uterus, she's biologically not able to conceive, or she has repeated abortions, more than 5 abortions, or more than repeated 6 IVF failures, then only I like to send this patient for surrogacy, ma'am.
Dr. Milind Shah, what do you say?
Yeah, but Kalyan, I wanted to add one thing to you, where the indications say by guidelines as well, some of the medical conditions of that particular mother, they actually create more risk to that particular patient as far as carrying the pregnancy is concerned. So it actually depends. If you feel that the pregnancy risk will be more in that particular given couple, we can advise surrogacy. But
Yes. So in this case, we can advise. Actually, I
Again, their
discussed
choice.
and
We'll have to do
I've discussed with many people, and renal transplant is an indication, though
Yes.
pregnancies have been reported in women who have renal transplant, but usually patient herself is so scared, because even when she used to come to the hospital, these patients, they'll say, please change the sheets, use everything disposable. I'm very, very prone to infection. So this is a right indication, though you can discuss that your patients like you can undergo normal pregnancy also. Now she did not want to undergo ovarian stimulation also, so ovum donation was arranged. ICSI was done with her husband's sperm, and all the formalities were done. Now surrogate was provided through the center where IVF was done. So is this correct, Dr. Milind?
Hello.
Hello. Yes. Yes.
Yeah. Can you just repeat it, Asha? I got disconnected in between. Please repeat it.
This surrogate was provided through the center who did IVF. Supposing we did the IVF, so it was this surrogate was provided through our center. So do you think the surrogate should be provided through the bank or through the IVF center itself?
Yeah. Actually, again, it differs from city to city. You know, especially in the metropolitan cities, we find there are bureaus who give actually surrogate mothers as well. But there are a lot of legal implications to that particular thing. In smaller cities, what we call as district places, again, things are different. The scenario is different. We also need to take part in the primary counseling. But eventually, whenever it comes to the legal formalities, I think we should give it to the advocate and the respective couples. Otherwise, there are many complications which keep on coming up as we read in the newspapers.
I agree. The ICMR guidelines, they suggest that the surrogate should be taken
away from that,
rather than the person who is doing IVF should not get involved. And I think it is true also. It prevents you lots of hassle. Now, this patient underwent all the screening and even the medical screening, including ECG, echo, etc. Now, beta HCG came out as 3,000. Dr. Kalyan Vermadi.
Again, there will be a fetal gestation.
Yes,
and
but do you think transferring 3 embryos in this particular case was right?
No, ma'am, this was a wrong decision. Now we should follow to single embryo transfer, and that to be preferably day 5 blastocyst embryo is better option. And as the surrogacy, you are giving a risk, increasing the risk of that mother. So it is not done rightly, ma'am.
Yes. So ideally, single embryo transfer should have been done, because this is a patient with proven fertility. So why put in 2 or 3? And here 3 embryos have been put. Now this patient wants to undergo termination because she doesn't want to undergo fetal reduction. So is it right for her to undergo termination? Can she undergo termination, Milind?
Yeah, now actually it depends, because that surrogate mother will be now exposed to all that risk of multiple fetal pregnancies. But again, this question is more of a social concern rather than the medical indication, because we have an option of reduction as well. But it again depends on the whatever agreement has been done, because in agreement quite often we write about these complications, as well as the, whether the patient will get multifetal pregnancy, whether she will get aneuploidies in that particular fetus, whether she will develop some medical complications, and all those clauses are very well covered actually in the agreement.
So the thing is that if she wants to undergo termination, she can undergo termination, but she has to return all the money and everything. But if you cannot force her to continue the pregnancy, though the everything is written down, but still you can't force her to continue. And if she undergoes fetal reduction, then the consent has to be from both the commissioning couple as well as the surrogate. Now this surrogate lives away from the Indore. It is nearby city Ujjain, and there only she develops preeclampsia. Relatives did not have time to bring her here, so delivery was done there. Now obstetrician there is not ready to put the name of commissioning mother for birth certificate. So what to do?
Again, it is a big actually the dilemma, but we need to speak with the obstetrician. We need to tell them, we need to send them the document which we have created actually before subjecting the couple for the surrogacy, and we should counsel. Quite often we understand that every OBGYN in our country is not dealing with the surrogate pregnancies.
Yes.
And that's why when they deliver, they get those dilemmas. They also
Yes. So basically, we have
speak
to
with the
show
local
all the
population
papers.
people and
Yes.
medical consultant
Yes.
we need to do.
Yeah, so we should
Yes,
really
papers,
discuss and give them the proof that IVF has occurred here. And ideally, this patient should be carrying a card that she is a surrogate of so and so. So that will again prevent the hassles. Anyway, the name of the commissioning mother was done, and but babies were still with the surrogate, and she had started the breastfeeding. So, do you think breastfeeding should be allowed, Kalyan?
No, ma'am, it is allowed for this. And as such, there are problems starting that this has not delivered in the center. This mother is having certain problems. He might develop an emotional bonding with the babies. So as far as possible, it should not be allowed, ma'am.
Yes. So ideally, it should not be, and if at all, then that has to be a contract between the commissioning mother and the surrogate, because there is no law saying anything regarding that. And whenever these babies were to be handed, but that they were handed only, she said, if the amount is given to her in cash. So I think we should not deal with cash in such patients. Always it has to be through the
by check, yeah.
Yeah. Now, once the money matter got sorted out, she gives only the female child and does not want to give the male child. In retrospect, came to know that she had infertility and was wanting a male child.
So
this is Karan Johar's movie coming up, ma'am.
This is really a finished story, Asha. We can have a very good movie on this particular case. Yeah.
Again, she was counseled. Again, she was counseled, and they took the twins away. Now the commissioning mother has looked after the babies, but somehow because she is immunocompromised and she developed septicemia 3 years later, and she died. Now husband has to remarry because it is in the movie. So the husband has remarried, but this is a 39-year-old lady, and she has had previous ovarian failures, and she wants one more baby. So husband remembers of the frozen embryos in the lab and wants to transfer those in the second wife. So what is the legal scenario?
Ma'am, you should write a Bollywood movie first, and then about the scenario. Now, if as a ART consultant, I am supposed to give them embryo if it is written in the bond that has to be given to the husband or wife, whoever is alive afterwards, can be given for minimum 3 to 5 years. That can be done, but stating that the fertility potential is decreasing as the time is going to increase, and there are certain laws where the consent holds important in this scenario, and whatever consent has been taken by the clinic, you have to decide accordingly, ma'am.
Correct. So
yeah.
I think
rather, Asha, before you showed this particular slide, I was about to say that either now I will call Dr. MC Patel or I will call Dr. Girish Kumtekar from Solapur city to find out the solution in such a dramatic scenario.
आपके दिल की बात सुन ली, and Dr. MC Patel is there at your service.
Yes.
Now coming to the case 4, this case has been referred to you by an IVF center at 13 weeks of gestation. What information do you seek from the patient in such a scenario? I mean to say, what information should the IVF want to have from the IVF specialist who did the?
Ma'am, this is a policy that those gynecologists who refer the patient, we give them a cheat saying that this was the first or whatever the attempt of the IVF, whether it was a ovum donation cycle or embryo donation cycle or self cycle. Thirdly, till what date you are supposed to give ecosprin, low molecular heparin, and all the other concern history, whether this is sperms are used by a husband or they are donor sperms, everything has to be written nicely. What was the course of treatment given, and then only you are supposed to refer with the NT scan report.
And you should really give the details of the donor also. What was the age of donor? Because what happens, this patient will undergo double marker test, and you have to write the date or age of the donor, not the age of the patient herself. So it's very important that all these things are documented. Even the blood group of donor should be written there, so that if even for neonatologists, this may sometimes be important. So all the details should be there. And as I was discussing earlier on also, that when frozen embryo transfer was done, was it on a natural cycle or on HRT cycle? Now this patient has singleton pregnancy, and she's having multiple episodes of spotting in her early pregnancy. And at NT scan, the placenta was seen to be covering the os. So how would you counsel this patient now?
Ideally, I should say that there are high chances of placenta previa in these patients, but because it is only 12 weeks of gestation, these small episodes will go off, and as the uterus grows, placenta might go up, and she might not be a placenta previa case. But every month sonography is must for this, and it is found that placenta previa is slightly more common in IVF pregnancies than spontaneous conception patients.
Yes. Now, Dr. Milin, her ultrasound was done and that showed that it is placenta previa. So are you just satisfied with this information that it is placenta previa, or you want to know something else?
No, we need to actually understand the placenta accreta syndrome as well in this particular. Basically, one more clinical point one need to take into consideration, that is whenever patient have the adhesions, placental adhesions having low-lying placenta, that is one of the clinical feature. But that is, not applicable to each and every case. So we need to have more additional ultrasound findings and the Doppler study to understand whether we are dealing with the placenta accreta syndrome, and accordingly we'll have to plan her pregnancy as well as delivery to go ahead with the good outcome. Yeah.
And when would you deliver her, and what sort of problems are you anticipating, and what sort of preparation would you do?
Yeah, we unless she has, we can take this pregnancy up to 37 weeks unless there are major 2 actually episodes of heavy bout, and we can take them up to 37 weeks. But at the time of actually delivery, again, we need to keep ourselves very much ready for the placenta accreta by keeping adequate blood and plasma ready, as well as keeping a good team ready who can deal with this particular cesarean case.
So it's very, very important to have a multidisciplinary approach and be prepared with everything. And I think all those who are very good in obstetrics will do wonders in such a case. We ultimately ended up doing hysterectomy in this patient. But then again, it depends on your experience and at that particular time, whether you can leave the placenta or you can remove that small piece of adherent piece of the myometrium and do the surgery. So all those things can be done. And there are all these guidelines about placenta accreta, and it has been found in the studies that embryo transfer associated with HRT is associated with more placenta accreta syndrome. So that reason I'm talking all the time about HRT and embryo transfer. And as such, also ART pregnancies are associated with more placental problems, right from premature rupture of membranes to placenta previa to placental abruption. So I think we should really be very watchful in these patients that they are associated with placental complications. Now coming to case 5, this is a case where this lady has been married for 8 years and had OD IVF, and she was referred for antenatal. She was having some antenatal care with obstetrician, but during Corona time, people were really not looking at that initially when it was in March, August. People were really not keen on taking any obstetrics, so she landed with us at 24 weeks, and that time BP was 160/90, and she had twin pregnancy with mild uteroplacental insufficiency and proteinuria 3+. So LDH was normal. So we thought we should really buy some time. So we gave her labetalol and steroid cover and waited. So 6 days later, her BP went up to 190/100 and had severe headaches. So nevirapine was added, which was further adding to her headache. But anyway, because the patient was very keen that doctor, we were very itchy to to terminate the pregnancy, but she was so bent upon that, please wait, please wait. So we waited. at 25 weeks 1 day. That day we thought that now we have to deliver because it was BP was 180/100, proteinuria, severe headache, and some breathlessness also. So gave her injection magnesium sulfate both for the neuroprotection of the baby as well as a prevention of eclampsia. And but patient settled down a little bit and the relatives refused to give consent for the cesarean. So my worry was that if second time she develops impending eclampsia, she settled down a little bit, then should I be repeating magnesium sulfate or not? So what is your view, Kalyan?
See, basically it is set. Hello?
You can go ahead, sir.
Yes, Milind. Milind, your connectivity is
Hello?
not that good. Yeah.
Yeah. Now see, yes. Yeah. Now see, basically it happens because the clinical picture improves. But what I always suspect in those cases, the organic damage, which need to be evaluated and spoken with the relatives. Otherwise, one find actually the day she may get some severe damage to some of the vital organs. And as we have decided to terminate the pregnancy, I think we should again intensify our counseling to see that the maternal actually health and her life is more important in this particular scenario.
True. So it's
in
very,
many
very
ways,
important.
as we have
Yeah.
protected the baby pet, which is little early actually, less than 26 weeks, but sometimes we keep ourselves little lenient as well, though the guidelines say after 26 weeks it has a role for the neuroprotection.
Yes.
And then definitely we should go ahead with the termination of pregnancy.
Yes.
Ma'am, I'd like to add here, ma'am.
Yes, Kalyan.
Because patient has PIH, severe preeclampsia, there is a role of dual neuroprotection which you are giving is first is magnesium sulfate as well as you are given dexamethasone to her.
Yes.
And secondly, you are talking about the second dose of magnesium sulfate. If she becomes severe preeclamptic where she is about to throw a convulsion, then there is a role of giving magnesium sulfate again for 24 hours. Usually we start with precharged regime and followed by IV infusion. We can start 1 gram per hour depending on that, ma'am.
Yeah,
and
this
because of the drug, newer drug like labetalol, it has been seen that the conversion has been decreased, and labevat can be safely given as doses of 200 milligram TDS or maximum till 800 to 1000 milligram per day can be given in this patient.
Right.
As this was a precious pregnancy, you are trying to delay for 2 to 3 days, which is very important because depending on that, the weight of the baby is going to be decided, ma'am.
Okay. This webinar I have done at many places, and the inputs that I got was that one can think about doing magnesium levels, one thing. Secondly, they said that after 48 hours, if the patient goes into impending eclampsia, then you can repeat the magnesium sulfate. So these were the 2 inputs I got from other people.
Okay.
So now 4 days later, now this is it. 4 days later, patient developed sudden left ventricular failure. She could not even sit, and it was such a terrible scene, I can tell you. It was managed with IV furosemide, labetalol, nitroglycerin, and I gave her magnesium sulfate. I said, nothing doing, let's give, and took her for emergency cesarean section, which was done in the midnight at, I think, 12 o'clock or 1 o'clock. And this type of babies were delivered, 850 grams and 750 grams with hardly any chance of survival. But we have a very good NICU and a very good neonatologist trained abroad, and she hardly uses antibiotics, and she's a different kind of person. So she said that, no, Dr. Asha, we will try. But now the finances were a big problem. So I had to really beg the administrators to reduce the cost and everything. But whatever said and done, these babies were in NICU for, one was for 63 days and another was for 54 days. And the expenditure was more than 10 lakhs after all the concession. So what I feel is it not the time to do single embryo transfer?
I'm rightly said. Now whole Europe is accepting that single embryo transfer is the must. In India also, we should go for a day 4, day 5 embryo transfer with single embryo transfer, preferably blastocyst. But here, because so many centers are still doing batch ICSI, the people are coming from out, they are doing this embryo transfer on day 2 or day 3. So they want success rate. So they are putting 2 to 3 embryos. Those who have good endometrial receptivity are going to land up into multi-fetal gestation. Those who are not having good endometrial receptivity are going to fail. So we have to accept that the success rate of IVF is 50% around, and take-home baby rate is around 40%. Everybody is not Milind Patil to give 86% success rate consecutively. So it's better to accept this success rate and go for single embryo transfer. If everybody is going with single embryo transfer, even patients are going to feel better that only one embryo is to be put and not 2 to 3 embryos to be put.
Totally agree. Totally agree. Very good. Dr. Milind, you want to give some inputs?
Yeah, basically, see, this is the difference in the practices abroad and in our country. In abroad, actually, they always follow the guidelines, and accordingly, they need to go ahead because there are so many medical-legal problems as well. Here, actually, in our country, there's a lot of mushrooming of many centers, ART centers in every city of India. And everyone looks at the success rate, which is the main criteria. But at the same time, many of them, behind those success stories, there are many complications.
Yes, yes, true. So I think this is very, very important.
And that's
yes.
why one to think of safety of the mother as well as the baby and the long-term implications of all these procedures as well as their outcome. And accordingly, one need to decide. And slowly, I'm very sure with coming days, the more ICMR actually intervention, definitely it will happen, so that we'll slowly go towards single embryo transfer as suggested by Kalyan as well, by properly doing day 5 or day 6 transfer. Yeah.
So our conclusion is treat each pregnancy as a high-risk pregnancy, multidisciplinary approach amongst the ART specialist, embryologist, high-risk obstetrician, fetal medicine specialist is very, very important. Early screening and prediction of potential complications is also very important. So we all, Dr. Milind, Dr. Kalyan and myself, we thank you very much for a patient listening and excellent discussions. I hope you liked the discussion amongst three of us. Thank you very much. And I take this opportunity. Can I?
Thank you very much, Asha. In fact, your cases were really brain teasing, and it was really great experience to discuss these cases, because these are lessons we always learn from each other, and that's why it was a wonderful panel discussion. I must say that. So on behalf of two of us as well, we congratulate you for all those actually wonderful cases, and I wish you all the best for your future venture of your candidature. Yeah.
Thank you. Thank you. Yes, Kalyan.
Yes, ma'am. Cases were really, really innovative. The role of obstetrician is still important, even if you are doing ART practices. The basic obstetrician who is handling the emergencies, handling the high-risk cases. If you make up a good team with ART specialist and obstetrician, then you can have a good outcome, because it's really important. And we wish you all the best for your VP elections, and voting is going to start tomorrow.
Thank you.
And also, I'd like to urge that I am standing for a treasurer post of IAG. Kindly vote for me also.
All the best. All the best. All the best.
Yeah, all the best.
So, again, I request you to vote and support me. And my vision is to promote operative skills and infertility workshops all across the country, encourage research and publication, because that is what I like. Awareness program for fitness of FOXY members is very, very important, and promote public awareness on fertility assessment and counseling of youngsters, so that the train is not gone before and by the time they plan to conceive. So this is my vision, and friends, all friends from Maharashtra, please support me. Thank you so much.
All the best.
Can I just add one line to the discussion?
Hello.
Yes.
Raju sir, bola.
Yes.
Yeah, just one line to the discussion. Whatever the method, whatever the way, whatever the treatment the patient has conceived, there is no role. I boldly say that, underline italic words, no role of conservative treatment in patients with severe preeclampsia. Pregnancy must be terminated.
Yeah.
Yes. Yes. It is a
Yes.
sword.
Because mother is more important than that fetus, ma'am.
Absolutely. 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 Agree, totally agree, because that sword is on your head, and something will go wrong and then you had it. So it's very important that be safe and deliver the patient in time. Absolutely, I agree you. And I
Good.
wish
Yeah,
this
very
corona
true.
crisis goes away and I'm able to invite you all to the cleanest city of India, Indore, which has been the cleanest city for the consecutive 4th time in last 4 years. So thank you very much, and I welcome you
Your
all.
conferences are really, your
Thank
conferences are really great, ma'am. Because
Thank
we
you.
have witnessed ISAR conference, which was one of the best conferences we have attended. So we'll come to Indore definitely, ma'am.
Great, great. Thank you so much.
Thank you once again all. May I, hello?
Yes,
Dr.
sir.
Kiran, madam,
Yeah.
dhanyawad.
Thank you.
Yes, Kiran.
Thank you. May I request our clinical secretary, Dr. Amruta Kunthekar, to propose the vote of thanks? Hello, Amruta? By the time, I really am very thankful to all of you, and really very nice and great discussion, and so many things we have learned to newer things to take as carry home messages.
Am I audible, madam? Am I audible?
Yes, you are
Yeah,
audible.
yeah. Yes, Amruta, you can speak. Yeah.
Yes.
Good afternoon, everybody. It was a very nice CME. First of all, I would like to thank the speakers, Dr. Milind Patil sir and Dr. Rajiv Dabde sir. The presentations were really rich with knowledge and information, and as well as practical tips. I would also like to thank our experts, Dr. Asha Bakshi madam, Dr. Melinda sir, and Dr. Kalyan Barmade sir. They really guided us with their vast clinical experience and acumen. I would also like to thank our 4 chairpersons, Dr. Ovarian madam and Dr. Pandit Palaskar sir for the first session, and Dr. Dhamre madam and Dr. Lata Agrawal madam for the second session. I would also like to thank our educational partners and the pharma. And last but not the least, I would like to thank our president, Dr. Kiran Sada madam, and our secretary, Dr. Madhura Virkar madam, who have been pivotal in organizing this CME.
Thank you very much.
Sure, thank you.
Yeah.
Have a great Sunday.
Thank you.
Yeah,
So
great
much.
Sunday.
Thanks,
Bye-bye.
Thank you all for being
Thanks,
with
everybody.
us.
Thanks.
So all of you are with us. Thank you very much.
Thank you, madam. Just 1 minute. Our Rajiv Agrawal sir is there. He just have the vote of thanks, please, from him.
Yeah.
Sure.
Okay.
Yeah, thank you, Kishore. Thank you, Zigo. On behalf of MKO Pharmaceutical Limited, I thank Solapur Obs and Gynec Society. I thank Dr. Asha Bakshi and Dr. Milind Shah for initiating this wonderful webinar. Thank you very much, sir. And I thank all the chairpersons. I thank speakers, Dr. Milind Patil, Dr. Rajiv Davde, sir, for a wonderful presentation. And our experts, Dr. Kalyan Baramde, Dr. Asha Bakshi, Dr. Milind Shah. Thank you once again. We, on behalf of MQ, wish you very safe and healthy life. Stay safe. कोरोना से मुक्त रहिए, यही हमारी आपसे ऊपर वाले से प्रार्थना है. Thank you very much. And we
thank you, Raju.
Asha Bakshi for this election is coming, to wish all the best to Dr. Asha Bakshi, Dr. Kalyan also for treasurer position of IIG. Thank you very much.
Thank you, Raju.
Thank you very much, sir.
Thank you.
Thanks, Dr. Kiran. Thanks, Dr. Madhura.
Thank you.
Thank you.
Thank you, Dr. Milind
Thank you,
Patil.
madam. Thank
Milind
you.
Shah, sir. Thank you very much.
Yeah,
Thank you, Dr. Kiran.
Thank you very
everybody.
much. Thank
Thank
you.
you.
Thank you,
Okay,
everyone.
bye-bye.
Thank you, madam.
Thanks. Bye.
Bye. Bye.
Everybody's permission, may I close the event?
Yeah.
Yeah, you can
You
do
can
that. Yeah. Thank you.
Thank you, Kiran, madam.